Good morning. My name is Weil. I'm Editor-in-Chief of Health Affairs. We're thrilled today to be releasing the November issue, which is devoted to the topic of patient safety. We're grateful to the Gordon and Betty Moore Foundation for their support of the issue, the briefing today, and our ability to promote the importance of this topic. My comments at the beginnings of these events are often fairly cursory. I'll keep it brief, but I want to say a few more words than I sometimes do, because my sense is that this thematic issue exemplifies really what we do best at Health Affairs, and since I'm Editor-in-Chief, I get to stand up here and be proud for a few minutes in front of you. Patient safety is an important issue, but when we talk about policy, there's often a lot of focus at very distinct points. A bill passes, a court case is decided, or in this instance, I would say the most cited event is the then Institute of Medicine, now National Academy of Medicine, report to Err Is Human, with the subsequent report Crossing the Quality Chasm. These were catalysts for change, and there's no denying the important role that they played. But policy evolves, and our understanding of policy evolves, and what we like to do at Health Affairs is remind ourselves and the health policy community that issues don't just come and a bill is passed and then they're solved. They evolve, and our understanding of them evolves. A tremendous amount of effort went into addressing concerns around patient safety in the wake of the To Err Is Human report. And I would never want to downplay how much attention and really terrific work went into addressing what was documented in that report. But with now almost 2 decades having passed, we've learned some things that work and some things that don't, but we've also learned a lot about where the focus needs to go next. And that's what we like to do at Health Affairs, is to keep the policy discussion current and not see patient safety as something that we discovered 2 decades ago, reported on, solved, and moved on. This is a topic, like so many, that we came to understand. We elevated its importance. The system had a tremendous response, but now our understanding of it continues to evolve. So, not to get too far ahead of ourselves in the content, but so much of the early efforts were focused on hospitals because so much of the evidence about safety came from hospitals. We now understand, as important as that is, that we need to look in lots of other places if we're serious about safety. There were great hopes that things like checklists and process improvement strategies could, in a matter of a couple of years, with appropriate documentation of errors, turn us in a completely new direction. And what have we learned? We've learned how changing systems is complex, that these are systems issues, and systems are resistant to change, not out of any ill will. That's just how systems work. And so sustained effort is required. And we've learned that things that we said we wanted to do, we haven't really finished the job. So just as I say, from the perspective of Health Affairs, it's a privilege to be able to pause, which is what a thematic issue does, and take stock of such an important topic, and to try to not just reflect on what we've learned, but set the course for the future based on what we've learned. And that's my ambition, and if I may say so myself, I think the collection of papers does a terrific job in that. I always remind folks that when we have thematic issues, we do have a data graphic. It's a 2-page spread that captures some of the information from the issue, but of course not all of it. Now, when we set the event for today, it's election day, but midterms, no one votes, right? You don't worry that people will be otherwise occupied. Well, it's not exactly our typical midterm election, but we're thrilled that you're here. We have more than 200 people registered watching online, and then, of course, we'll archive the event, and we'll have many more viewers over the subsequent months and years. So thank you for coming out on this rainy day with lots else on the world's agenda, but hopefully this will give you, there are no election results that will come out before the end of this, so we hope that we'll have your attention for the rest of the morning. It's my pleasure now to introduce Diane Schweitzer, Acting Chief Program Officer for Patient Care at the Gordon and Betty Moore Foundation, who we've worked with, of course, in the production of this issue. She was for 6 years a member of the senior management team at the Robin Hood Foundation as well. She's worked as a strategy consultant at Booz Allen Hamilton, began her career and worked for a time as an associate at Morgan Stanley. And since we've had the pleasure of the guidance of the foundation in pulling this issue together, it's my pleasure to introduce to you Diane Schweitzer.
Thank you, Alan. On behalf of the Gordon and Betty Moore Foundation, I'm delighted to be here today to welcome you all to this really special event and to this special issue. Many thanks to Alan and your team. As always, we've worked on 6 or 7 special issues at this point, and we have a great relationship. We welcome everyone who's in the room and also those who are on the webcast and also participating through the live tweets option. And of course, thank you so much to all of the authors and presenters who are in the room, and also I understand we have some who are calling in to present today too. As Alan mentioned, this is a really timely issue. Almost 2 decades after the publication of Err Is Human really did open up this issue and highlight the importance of this work. And as Alan has mentioned, a lot of the early work has been in the hospital, and the Gordon and Betty Moore Foundation jumped on the bandwagon and supported the 100,000 Lives campaign, and also through the nursing initiative focused on patient quality and safety in hospitals in the Bay Area and Greater Sacramento. Now is the time to look at the current state of the research, the gaps, the opportunities as healthcare changes so rapidly, and also to make sure that we don't lose the important attention on patient safety. The foundation has deep roots in patient safety, which stem from Betty Moore herself. Many years as a patient and as a family caregiver have influenced her interest in this topic. Betty herself experienced a medication error. And in typical Betty fashion, she said, "What do we do so that this never happens to anyone else?" We've been funding in the area of patient safety and quality for over 15 years, and I'm delighted to see some of the people we work with over the years here, both as participants, as presenters, as authors. The paper from David Bates and Hardeep Singh that provided a really excellent overview of where we've come and looking, as Alan mentioned, to the future, where are some of the areas for opportunity, highlighted some of the things that the foundation is working on currently. We have been looking at patient safety in the outpatient setting. We are looking at health IT. And just last week, we announced a new initiative in diagnostic excellence. The foundation will be investing $85 million over the next 6 years to improve the diagnosis process. And the aims are to reduce harms from erroneous and delayed diagnoses, to reduce the cost and burden on families, patients, and the system, to improve patient outcomes, and to save lives. So we're really excited about that new initiative that fits nicely with what is being shown as kind of the next horizon in this field, and to work on the other issues that were identified. So with that, again, I welcome you. Thank you so much for being here. We look forward to today's excellent program, to reading the issue, and also to seeing how we all take action to move this forward. Thank you so much.
Thank you, Diane, and again, thank you to the Foundation for the support of the issue. When we begin a process of a thematic issue, we bring a collection of people together to help us think it through, and one of the participants in that meeting was Dr. Jeff Brady, who will be speaking next. He's a leader in the field, and I do want to point out, I hadn't even noticed it until we were coming right to the publication date, that the Agency for Healthcare Research and Quality was the source of funding or data for, I think, half the papers in this issue. And so if you're wondering about sort of the value and the contribution of AHRQ to our understanding of patient safety, our promotion of safety, and our ability to move this issue forward, I think it's clearly made in this issue. As I say, that was not something we did by design, but but it was interesting to see. Jeff Brady has been the director of the Center for Quality Improvement and Patient Safety at AHRQ since 2014. He's a Rear Admiral in the U.S. Public Health Service, and he leads a part of the agency that conducts a number of the programs, including patient safety research, healthcare-associated infection prevention, the National Healthcare Quality and Disparities Report, and the CAPS, Consumer Assessment of Healthcare Providers and Systems. He's been a medical officer and clinical reviewer for the FDA's Office of Vaccines and was a medical epidemiologist for the Department of Defense and a primary care physician in the U.S. Navy. We appreciate your leadership, and Dr. Brady, we look forward to your remarks.
Okay, well, thank you very much, Alan, and thank you also, Diane. Diane, your work with Gordon and Betty Moore Foundation, all that you described that you're doing is so critical and important to this field. Alan, I think you did a great job of describing, I think, the purpose of this health affairs brief and essentially all of your work. And so that work to keep the spotlight on patient safety is so much appreciated. I think the importance of not only looking back, but looking ahead, I think can't be overstated. Good morning to all of you. It's a privilege to be here today to welcome everybody to learn more about this pressing issue of patient safety. I wish for those of you who aren't in the room could sort of capture and see the energy that I see. It's sometimes subtle. It's sort of like patient safety itself. It's behind the scenes, but it's definitely there. It's operating. And that is probably one of the most fun things about my job, is to see that energy and, most importantly, the products that it generates. The excellent work of all the articles in the health affairs issue, I think, is very representative of that energy and that purpose and, frankly, that progress that we're making. But we know that our work is far from over. Whether it's keeping the patient and patient safety, which I think is a big part of our work in AHRQ, better understanding the role of systems, or scaling the latest interventions to improve safety. Again, there is much more to be done. In the nearly 20 years since the landmark report to Err Is Human was released, we've made some really great strides. We've seen measurable reductions in patient harm, including fewer adverse drug events, injuries from falls, and these and many other improvements help prevent an estimated 8,000 deaths and saved $2.9 billion between 2014 and 2016. So we're talking about real impacts here that, again, matter to patients. And according to those results that I mentioned are according to our latest results from the national scorecard that focus on just the hospital setting alone for those benefits, and we continue to track those hopeful improvements. We've seen how the use of a safety program called the Comprehensive Unit-Based Safety Program, or CUSP for shorthand, helped hospital ICU staffs reduce central line-associated bloodstream infections by more than 40%. CUSP has been adapted to prevent other infections in various settings, such as catheter-associated urinary tract infections, or CAUTIs, in hospitals, and also long-term care facilities. So we're expanding and adapting that to many different settings. And we've seen some similar impactful results. This is real progress in real patients, but again, we're not there yet. We're looking back, but also, most importantly, looking ahead. And we've got very enthusiastic support from our current leadership, including Mr. Gopal Khanna, who directs the agency. And so, again, that's part of that energy and excitement and that drive to do more, because there is much more to be done. So today we'll hear about how hospitals in South Carolina used a checklist to improve care for surgery patients. But we'll also hear about how we need to do a better job of making electronic prescribing safer, and how the design and architecture of our healthcare settings makes a big difference in how safe they are. These diverse examples represent the very active frontier of patient safety. Again, that energy, this is still happening, and the folks who are expert in this field are expert at going out and finding these problems, but most importantly, in also finding solutions. And together with the powerful combination of safety research and improvement, which is targeting problems, again, creating solutions, and most importantly, generating results. We know that the results we achieve from safer care are also highly valued by patients and their families. This really matters to patients, and they also want to be engaged in this work, and we're doing a better job at doing just that as well. So as Alan mentioned, my role is to direct the patient safety activities at the Agency for Healthcare Research and Quality. We may be a little bit like patient safety in some regards. I think we're very important. I'm a little biased on that point. Thankfully, some others think that also, but we're sort of not as visible as maybe we should be. Hopefully this issue will help to remedy that situation too, because again, this is important not only to us as professions in the field, but we're also patients too. And I'm impressed by the number of stories that I hear when we get together to talk about a technical issue. And in fact, we are all sort of subject to those same risks and hazards. And it's again, very personal to all of us, as well it should be. So the other key point I want to make is that I'm constantly reminded that patient safety is a team sport. There are very few projects where one person or even one organization can do it alone. And it takes all of us, federal leaders, researchers, health system CEOs, frontline physicians and nurses, and again, most importantly, patients and families, to help ensure that patients aren't harmed during the course of their care. As several of the papers that are being released today show, we still are a ways off from having an accurate system for measuring how we're doing and tracking our progress. We're all getting better at that, and I think that's an important focus of our collective work. At AHRQ, we're working with our colleagues in the Department of Health and Human Services and also in the private sector to make sure that the quality and safety measures we produce are actually enhancing our ability to efficiently measure quality with the ultimate goal of improvement. Measurement is certainly not the end. It's an important means to the end. So we need to make sure that we're not adding to reporting burden, but again, measures that matter is a good phrase that captures what I think drives us in our measurement work. Because AHRQ is the federal government's lead patient safety agency, our portfolio is quite vast, much like the diversity that you see in the health affairs issue today. Our work includes producing quality measures and reports, reducing healthcare-associated infections. More than half of our research funding currently is allocated to this important problem, a set of problems, in fact, of healthcare-associated infections, and developing tools to help clinicians better engage patients and families as active participants in the pursuit of high-quality, safe care. We also help incubate new ideas in our patient safety learning labs. These are really impressive organizations throughout the country that we have the privilege of funding, and they're bringing together multidisciplinary teams and really creating the next wave of innovations. This is part of learning from what we see when we look back, but also looking ahead. And again, this interdisciplinary, multidisciplinary work is so important. It's challenging, but I think we're making progress on it. And again, most importantly, it's creating solutions and results. So Congress additionally, most recently gave AHRQ an additional $2 million in new funds to help advance the science of diagnostic safety. And for those of you who have some knowledge of that problem, it's going to require all of us in healthcare to up our game in terms of addressing the challenges that lurk among diagnostic safety issues. So making sure that patients get accurate, timely diagnosis that are also communicated to them in a way that they can understand is one of the healthcare system's most urgent challenges. An estimated 12 million patients are affected by diagnostic error. And that's just each year, with about 4 million of them suffering serious harm. I think that's enough for me to stop there, but in order to pull more audiences in, it's also helpful to look at the cost of diagnostic error to the U.S. healthcare system. It's estimated to be more than $100 billion annually. That's collective cost burden on our society that we actually have the tools and resources to address. Again, looking ahead to the challenges, but also potential solutions. So we can think of much better ways to spend $100 billion in waste, I think, and that would be an exciting problem to have. So in my work as co-chair of the National Steering Committee for Patient Safety, I join another colleague who has just been tremendous in this field, Dr. Tejal Gandhi. She's the Chief Clinical and Safety Officer for the Institute for Healthcare Improvement. I think the vision of both Dr. Gandhi and her entire organization and the field that we have the privilege of working with in looking across the patient safety landscape to make sure that we at ARC and all of the players in this important field are working in tandem and not tripping over each other. It's often really jarring to me that there are so many challenges for us to tackle, and better coordination is going to help us do that more efficiently and more effectively. So we want to all stay pointed in the same direction so that we can move faster down this path to our ultimate goal of zero patient harm. So ARC is very proud, as Alan mentioned, to have funded the research that's being presented today, and I'm really encouraged that this growing momentum and energy signals a sharpening focus on how to significantly reduce patient harm. I really thank you all for being here, and I look forward to hearing from such an esteemed group of patient safety experts and thinking together with all of you and hopefully a larger audience how we can move ahead to next steps. So thank you very much.
Okay, I'll let the two of you move to the audience, and as we have our first panelists come up, I'll just say a few words about the structure of our morning. We have three panels. The division of papers is always slightly arbitrary, but we're going to focus at the outset on what we call where is the patient in patient safety in the world of where people are increasingly trying to have patient-centered metrics. The role of the patient seems particularly important when it comes to safety. After a break, we'll talk about systems. Much of the work in the last 2 decades has been about reorienting reduction and elimination of harm from being viewed as a personal error to a system flaw that needs to be redesigned. And then our closing panel will include a number of papers of particular interventions designed to improve safety. I should say before we go into the panels that we invited the authors of all of our papers. I want to note the absence of two people who were unavailable, most important. David Bates was our theme advisor. He led the process of defining the issue and our review of abstracts and papers. Unfortunately, he can't be here. Dr. Bates is the Medical Director of Clinical and Quality Analysis Information Systems at Partners Healthcare, and he's the Chief of the Division of General Internal Medicine Primary Care at Brigham and Women's Hospital. Anjali Sharma also wrote an overview paper on this first topic that we're covering in the first panel, but was unable to be here. So when you get the issue, there will be papers that weren't presented today, so you'll have even more to look forward to. We'll structure our event today, for those of you who've been here before, as we typically do. We've asked each of our presenters to give a concise 7-minute summary of their work. I will tell you all as panelists, we don't have a remote, so use the down arrow on the keyboard here. You're going to hear from Linda Aiken, Claire Fagan Professor of Nursing, Professor of Sociology, Director of the Center for Health Outcomes and Policy Research, and Senior Fellow of the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Traber Davis Giardina, Health Services Researcher and Assistant Professor at Baylor College of Medicine and the Center for Innovations in Quality, Effectiveness, and Safety at the DeBakey VA Medical Center. Alan Kachalia, Chief Quality Officer and Vice President for Quality and Safety at Brigham and Women's Hospital in Boston. Tom Gallagher, Professor in the Departments of Medicine and Bioethics and Humanities at the University of Washington School of Medicine. And Morgan Shields, PhD student and NIAAA Fellow at the Institute for Behavioral Health, the Heller School for Social Policy and Management at Brandeis University. So let me turn it over first to Linda.
Good morning, everyone. It's great to be here and have the chance to see where we've been, where we need to go in patient safety. It's been 20 years since the Institute of Medicine shocked the healthcare community and the public by concluding that medical errors were among the 5 leading causes of death in our country. And since that time, there have been immense efforts in our country and around the world to reduce patient harm. And so here we are 2 decades later with the opportunity to take stock of what we've achieved. And we had the privilege, because of the Institute of Nursing Research and the Robert Wood Johnson Foundation support, to conduct an unusual study, really a panel study of hospitals and other organizations. I'm going to focus on our research on hospitals today. Normally, when we talk about surveying healthcare providers, patients, the public, we're doing cross-sectional studies. We did something different here. We anticipated that we really wanted to understand in specific organizations what they did to try to improve patient safety, and was there a result? Well, one of the major recommendations of the Institute of Medicine was that nurse clinical work environments needed to be transformed as a foundational initiative on which all safety interventions would be built. So we were interested in knowing the extent to which hospitals really have improved their work environments over the past 2 decades. So we studied 535 hospitals over the period 2005 to approximately to 2015. These are almost all of the hospitals in 4 large states of over 100 beds. And to get information about what went on in those hospitals during that period, we have information from over 800,000 patients about their care, and information from over 53,000 nurses as to what was going on in terms of quality and safety. So to give you an up-to-date view of the appraisals of patients and nurses about patient safety almost today, the results, I would say, were disappointing in terms of how much we had hoped we would accomplish in 2 decades. So still, a third of patients rate their hospitals as less than excellent. Almost a third of patients would not recommend their hospital to a family member or friend who needed care. We asked nurses, the over 50,000 nurses, specifically to grade the hospital in which they're practicing on patient safety, and nurses gave unfavorable scores, a letter grade of C, D, or F. A third of them gave unfavorable scores on patient safety. I could tell you as a professor that there's no student that wants a C, D, or F, even on an innocuous course. So you really don't want that grade on patient safety in a place where your life could depend upon it. And in addition, we know that health professionals, healthcare providers are experiencing high levels of burnout, which is a safety hazard. 31% of nurses are scoring in the high burnout range. And then particularly discouraging, if we look across all the 50,000 nurses, we asked them to appraise the work environment in hospitals where they were practicing. Over 80% rated their hospitals as having a less than excellent work environment. This is 2 decades after the IOM said we must transform nurse work environments to keep patients safe. So when we looked over time to see among these 535 hospitals how many of them actually improved their work environments with information at a baseline, and then 15 years later on the same hospitals, only 21% of these hospitals substantially improved their work environments, which means they improved their work environments more than 10%, which is not the highest bar to use. 71% basically remained the same, and 7% actually worsened in their work environments. Now, were there any consequences, positive or negative, to hospitals with regard to whether they improved their work environments or they didn't? So in the hospitals that improved their work environments at least more than 10%, patients rating their hospitals as excellent increased by 11%. Patients that would definitely recommend their hospitals increased by 8%, and these are the hospitals that made this substantial improvement in their work environments. And then nurses ranking patient safety, those patient safety grades improved over 15% in the hospitals that had improved work environments. In the hospitals that worsened, all of the patient safety metrics declined. One example of those that we report is that favorable hospital patient safety grade given by nurses in those hospitals that actually worsened in their work environments declined by 19%. And then where in those 71% of the hospitals where there was little improvement in nurse work environment, there was also little improvement in a range of patient safety indicators that had to do with whether patients were told about their medications before they were given, whether nurses felt free to question authority, whether nurses perceived that if they reported a negative event, that their mistakes would be held against them. So the whole range of general safety, global safety metrics, and patient safety culture were all affected by the hospitals that did improve their work environments. So where does this leave us going forward? And this is really the effort, I think, of this issue. We've accomplished a lot. We've made some improvements in patient safety, but everyone agrees we haven't made as much progress as we like to make, and the improvements have been uneven. So what do we need to do now? Well, from our results, we would include that we need to do what the Institute of Medicine recommended as a major recommendation almost 20 years ago, which we need to identify safe nurse staffing and supportive work environments as patient safety interventions. We really haven't done that. We've gone around the fringes, we focused on a lot of specific interventions, but it seems that we have not incorporated this idea that safe nurse staffing and work environments are foundational to being successful in preventing patient harm. We think that it would be very useful if the CMS would add to the website Hospital Compare nurse-to-patient ratio measures and to use the National Quality of Forum's endorsed measure of clinical work environment so hospitals could benchmark themselves off of other hospitals and the public could have some important feedback. Increasing clinician engagement in decision-making, not only nurses but physicians and others, very important to reducing clinician burnout and to keep patients safe. Magnet recognition has been a very successful and highly evidence-based intervention to improve patient outcomes and patient satisfaction. And then I want to end with just a comment on the blame-free culture that was recommended by the IOM. To err is human implied that we all make mistakes, but in order to have learning organizations, we have to have those errors identified so we can learn from them. One of our findings is that 50% of nurses fear their errors will be held against them. And that must be undermining the adverse event reporting systems that we are all using to judge whether we're making progress on patient safety. So we definitely need to change the organization and culture of care so that people feel safe in identifying errors and misses and make that change in the next 5 years for sure. Thank you very much.
Morning. I'm going to talk to you about patients' experiences with diagnostic errors. So as you already heard, diagnostic errors account for 12 million diagnostic errors in the outpatient setting. So that means 1 in 20 patients annually experience a diagnostic error. So that's a significant burden. And patients have a unique perspective to add to diagnostic error research. Patients are the one constant that occurs throughout the diagnostic error process. So engaging them and learning from their experiences is very important to better understand and ultimately reduce diagnostic error. Unfortunately, diagnostic errors are underreported. As mentioned, the incident reporting. So the causes of diagnostic error are often hidden, and the patient experience, unfortunately, is often missing from how we understand diagnostic errors. So we conducted a study to explore patients' experience specifically with diagnostic errors. We looked at patient and family reported narratives, and we identified 184 from a large survey of patient reporting adverse events. When we reviewed the narratives, we found that almost 75%, or 3/4 of the patient narratives and family reported narratives, included some type of problematic clinician behavior. And when I say that, I mean behaviors that fall outside of what we traditionally think of patient-centered care. So when we looked through those narratives, we identified 224 instances of patients discussing problematic behaviors. And we were able to go through and sort of categorize those behaviors into 4 larger themes or 4 larger categories. And I'm going to go through each one. The first is ignoring patient knowledge. So patients told stories of feeling like their physician or their clinicians weren't listening to them. When they talked about symptoms, they felt like maybe they were being dismissed or treated like the knowledge that they had about their own condition wasn't important in the diagnosis. The next category is disrespecting patients, and this is sort of the manner of communication from the clinician to the patient. So perhaps the patients felt that they were being treated rudely, they were being mistreated, or belittled or mocked when they were discussing their conditions or what was happening with them related to the diagnosis. The next category is failing to communicate. So in some instances, patients felt that their clinicians weren't responsive when they asked questions. A patient in a hospital may request the attending to come to the bedside and to discuss what was happening, and either the attending did not show at the bedside, or they would send a trainee, and the patient didn't understand why their doctor wasn't communicating directly with them. In other instances, in the outpatient setting, patients would call about symptoms that they'd like to discuss with their doctor, and they would never hear back. So they'd call multiple times and wouldn't ever hear back from their doctor. The last category, and probably the least salient, was manipulation or deception. So in some instances, patients felt that their doctors were using, or their clinicians were using fear to encourage them to make decisions quickly about treatment. And in some cases, they discouraged getting a second opinion when they wanted to maybe seek another doctor's opinion about what was happening. So why is all of this important? The patients are an integral part of the diagnosis, of course, but there's no current national policy or practice initiatives to gather patients' experience specifically of diagnostic errors. So one way to remedy that may be including patients through patient reporting, so that we really bring patients into the discussion and encourage them to talk about diagnostic errors that they've experienced. And we believe that, just based on our findings from this study, that patients' experience can supplement existing reporting systems. So as mentioned before, incident reporting has low reporting currently. So collecting patients may help us identify things that we are not capturing otherwise. As I mentioned in this study, these behaviors, which there may be no way to identify those without actually engaging the patients and bringing them into patient safety initiatives. So implementing patient reporting, this includes inviting patients first, but also identifying barriers. What would make a patient not report? What are the facilitators that might encourage them? So in healthcare systems, that might be encouraging patients to speak up, having a culture where we invite them to talk to someone, and we actually show them this: when something occurs that you think is problematic, this is who you talk to. And if we are going to begin collecting these experiences, we need to be monitoring those. So we need to identify patterns, what's happening in our system, and so that we can locate areas where we can actually intervene on those. And also we need to validate, we need to conduct chart reviews of these patient-reported diagnostic errors to see what is happening and identify factors and see what is also missing in the medical record. So some of the interventions we suggest are first physician accountability for these behaviors. And this may include intervening to really focus on the patient-physician relationship, to foster that relationship, to foster open communication, encouraging patients to speak up and ask questions, and also talk to physicians about how these professionalism relates to patient safety and how it may impact patient safety. And one of the ways that we think we could do that is through ongoing medical education, through CMEs, through actually in the licensing board exam, including modules related to professional communication. But I'd like to leave with you, we really encourage bringing patients into the discussion about patient safety. They have so much to offer about their experiences, and they can be an important part of the patient safety movement in general. Thank you.
Thank you. Excuse me, thank you. Good morning. It's a privilege to be here today to briefly present the article on behalf of my team. The article is entitled Effects of a Communication and Resolution Program on Hospitals' Malpractice Claims and Costs. I'd actually like to start by describing what I mean by communication and resolution. The terminology has actually evolved over time. These programs, when they first came out, they were called disclosure and offer programs, and eventually disclosure, apology, and offer programs. And regardless of the name given to the program or the approach, what they're really meant to include are the following steps. After a harmful event, that the hospital and the providers provide timely and meaningful communication to a patient, whether or not there was an error in care. It's followed by a rapid investigation to figure out what happened, an explanation, emotional support for patients, families, and providers, and of course an apology when appropriate if there was an error. Compensation is then proactively offered if care is found to be substandard, meaning that you don't wait for a patient to ask for compensation. If the hospital knows it made a mistake, it offers the compensation up front. And of course, one of the more important pieces as well is post-event learning. And by what we mean by this is you engage with the family to figure out how can you improve patient safety so this won't happen to another patient in the future. There's been a lot of interest in this type of approach, especially because it's seen as a professional and ethical imperative that can obviously advance transparency, improve patient trust, and of course, ultimately patient safety. Now, as straightforward as the concept is, it turns out that we still have a lot to learn about communication and resolution programs. There have been a few compelling successes reported at some systems. The first two that are most notable were at the Lexington VA and at the University of Michigan. And in both of these cases, the results indicated that after they implemented their CRP, or their Communication and Resolution Program, what they saw was a drop in their liability costs. Now, it's important to note in these early studies, there were really no peer group hospitals that were evaluated in these observational analyses, but nevertheless, these programs have been seen as providing this important proof of concept that you can disclose your errors and you don't have to see higher liability costs. And as a result, we've seen a rapid scale up in the US. A lot of hospitals have taken an interest in this approach. And one of the biggest things that we've learned along the way, it's actually very hard to implement these programs properly. And in fact, in the background, there's always this issue. People still worry that CRPs, if they're implemented at their sites or their centers, will still lead to higher liability risk. So this is where our analysis comes in. I was fortunate to be part of a coalition of hospitals called MACRME in Massachusetts, of hospitals and stakeholders that came together with one goal: to help hospitals implement CRPs in the state. As a result, we had the opportunity to evaluate the first two hospitals that had joined this coalition in their community sites as to what happened to liability after implementation. We were also very fortunate that a few peer hospitals in Massachusetts that had not implemented their CRPs were willing to share their clinical and their liability data with us so that we'd have that all-important comparison group to see what happens. This way we could look at the implementing sites and compare how they did to sites that did not implement. And you can see the categories there. The academic medical centers were BIDMC and Bay State Medical Center, and their community hospitals that we evaluated were Bay State Mary Lane and Bay State Franklin. And the comparison sites were 3 large Massachusetts AMCs and 3 large Massachusetts community hospitals. And what we did, I should point out, is that we looked at liability trends 6 years before implementation. Care was then implemented, or the CRPs were implemented in these sites between December of 2012 and May of 2013, and we followed these hospitals for 4.5 years after implementation. And here's what we found. When we look at the before and after trends at the intervention sites and the peer comparison sites, we saw that there were no changes in the trends at the comparison sites. And you can see that in the far right column there. So when you look at the outcomes, like whether or not these sites saw an increasing number of new claims, an increasing number of defense costs, what happened to claims receiving compensation, total compensation costs, and things like time to resolution, the sites that did not implement CRPs saw no change in their trend. And that should make sense. I think what's interesting is that when we look at the hospitals that did implement the CRPs, in 4 of the outcomes they saw no change, but at 2 of the community hospitals and one of the academic centers that we evaluated, those sites actually saw a significant drop in the number of new claims. And both our academic centers that we evaluated saw a significant drop in their defense costs. So what this has led us to conclude is that we didn't see the large cost savings that were reported by the early adopters. We just didn't see them here in Massachusetts. But it's important to note that these programs were implemented and there were no liability cost increases seen either. This suggests that hospitals really can do the right thing without increasing their liability exposure. And our hope is that as the data continues to accumulate showing that this is true, that the CRP discussion will move away from liability concerns and really move to how best do we implement these programs to serve patient and provider needs, and how best do we use these programs to leverage patient safety improvements. I'd like to say thank you, and like most things, nothing's done without a team. The team is listed up there, and I won't go into much detail, but I thank you very much for your time.
Well, good morning. On behalf of my co-authors, Michelle Mello, Bill Sage, Sigal Bell, Tim McDonald, and Eric Thomas, it's a pleasure to speak with you about the exciting work that's taking place around communication and resolution programs, which have considerable potential to enhance patient safety. Well, as Alan mentioned, communication and resolution programs are innovative initiatives to both prevent and respond to adverse events. We've touched already on their key elements, but there will be a quiz at the end of this, so I'm going to go through them again. They involve communicating openly with patients and families about adverse events, investigating the adverse events caused using rigorous system-based and human factors-based analysis, explain what happened to the patient and apologize, supporting clinicians, patients who are involved in these events, and then in those cases when an adverse event was due to substandard care, making a proactive offer of compensation. We're seeing a remarkable uptake of communication and resolution programs, and we estimate that over 200 organizations are implementing a CRP. But there are some critical questions, and we've identified 5 that we believe are pivotal to the success of these programs. This CRP uptake truly is exciting, but as Alan mentioned, the fidelity with which many organizations are implementing the model is often limited. Therefore, the first question is, how can greater adherence to core CRP practices be encouraged? Sometimes this inconsistent implementation involves using CRPs for some but not all cases. Other times, organizations are not employing all CRP practices for a given case, most commonly not offering compensation even though the adverse event was caused by substandard care. This inconsistent implementation gives fuel to critics who assert that these programs are merely claims management efforts. We believe that improving adherence to core CRP practices will hinge on using rigorous metrics, which are currently being developed and deployed, to assess the way that CRPs are being used. And we hope that this will help organizations use CRPs in a comprehensive and principled and systematic manner rather than cherry-picking cases and making sure that compensation is consistently offered when it's warranted. A second key question examines the degree to which CRP practices are evidence-based and linked to patient safety. While the evidence connecting CRPs to liability outcomes is strong, the relationship between CRPs and patient safety, despite its face validity, is largely theoretical. We suggest that while this evidence base is developing, organizations use a lens of quality improvement and the aforementioned metrics to enhance their CRP operations. Our third question addresses a frequent concern of CRP skeptics, namely, are offers of compensation made in CRPs fair to patients? Answering this question is difficult given the challenges of measuring the fairness of CRP offers. For now, we recommend that systematic processes for making fair CRP compensation offers be routinely followed, especially ensuring interested patients have access to attorney representation. Additional research is sorely needed around how patients and family members in CRPs think about the fairness of compensation. Fourth, how can CRPs ensure alignment with participants' needs? While CRPs have their origins partly in research documenting patients' and families' expectations for how adverse events should be handled, some have questioned whether CRPs are oriented more towards advancing the interests of healthcare institutions and liability insurers. Research documenting the experiences of patients and families with CRPs is emerging and suggests that there's considerable room for improvement. Such research should be expanded, especially using population-based samples of patients and families. In addition, many CRPs are appropriately developing programs to support clinicians following adverse events, a trend that should be encouraged. Finally, how can state and federal policymakers support CRPs? Going forward, there are strong arguments for viewing CRPs as essential components of high-quality, ethical medical care, rather than as alternative dispute resolution processes that compete with civil litigation. Accordingly, the policy changes most important to CRPs will further best practices, address specific impediments, and integrate CRPs with other health regulatory frameworks. Advancing CRPs will require policymakers address a number of important topics, including the National Practitioner Data Bank, ensuring Medicare subrogation rights take CRPs into account, partnering with state licensing boards, ensuring liability insurers' contracts with physicians do not prohibit disclosure and apology, and integrating CRPs into emerging payment and accountability metrics. The Communication and Resolution Program field has considerable promise but faces important challenges. Organizations that implement CRPs should strive for fidelity to the model and rigorously evaluate their performance with meaningful metrics. Closer partnerships and longer follow-up with patients and families who have been served by CRPs will be essential to understanding their experiences. Momentum for CRPs will continue to build without supportive legal reforms, but policymakers should consider how they might accelerate it, perhaps transitioning from voluntary to more prescriptive requirements. By honoring principles of transparency, quality improvement, and patient and family empowerment, organizations can use their CRPs to help revitalize the medical profession. Thank you.
Good morning. It's a privilege to be here. First, I would like to acknowledge my co-authors, Maureen Stewart of Brandeis University and Kathleen Delaney of Rush University. I would also like to acknowledge the National Institute on Alcohol Abuse and Alcoholism for my predoctoral training grant. Many people in this room have played vital roles in the robust efforts to improve patient safety over the past 20 years. However, behavioral health care has been slower to take up similar efforts. Inpatient psychiatry, in particular, has been largely absent from efforts to monitor and improve safety. This absence is in spite of real risks for both psychological and physical harm to particularly vulnerable patients. Investigative journalism has called attention to patient harm, covering issues such as abuse, neglect, understaffing, and sexual assault. Although research is limited, empirical evidence suggests adverse events are common. A 2018 study found an adverse event in 14.5% of psychiatric hospitalizations, though this is likely an underestimation. And these numbers fail to capture psychological harm, which is arguably a more salient concern in the psychiatric setting than in other hospital settings. Such safety can be compromised by experiences of physical harm, as well as depersonalization, humiliation, or feeling threatened. We know that inpatient psychiatry should be trauma-informed, and that trauma-informed care supports both physical and psychological safety. Trauma-informed care recognizes and addresses the effects of all types of trauma and the potential for re-traumatization within the healthcare setting. However, the likelihood that organizations will appropriately support frontline staff in delivering safe and trauma-informed care depends in part on systems-level factors. These include market features, regulation and monitoring, and research infrastructure. Market failures for inpatient psychiatric care are similar to, but arguably more severe than the market failures in the rest of healthcare. For example, not only do health plans and providers make decisions on behalf of patients, but so do the courts, such as with involuntary admission. These actors are likely not considering patient safety in their decisions. In addition, patients might find self-advocacy difficult due to their condition, power imbalances between the patient and provider, and stigma that can lead to patients' voices being discredited. Further, families often cannot be at the bedside or easily observe the treatment environment and care provided. Addressing patient safety in this setting is particularly important today given the 48% rise in for-profit beds from 2010 to 2016 as shown in this graph. This trend is likely to continue given recent policy changes, such as use of 1115 waivers and clarification in the regulatory rules surrounding Medicaid managed care. For-profit hospitals which do not have an explicit charitable mission may be more likely than nonprofits to exploit market failures in order to maximize profits. Indeed, the largest supplier of psychiatric beds in the country has seen dozens of facilities come under local and federal investigation for issues such as patient death and fraud, all while maintaining excessive profits and continuing to expand. In addition to ownership, low reimbursement and misaligned payment models could hinder organizations' ability to deliver safe care. Current payment models incentivize facilities to constrain resources. However, efforts to monitor quality are underway through CMS's Inpatient Psychiatric Facility Quality Reporting Program. While the program has limitations in its current form, such as not fully capturing the safety domain of quality and lack of patient-level data, It could serve as a viable vehicle to compel reporting of meaningful measures and improvement in patient safety. Regulatory and accreditation standards for inpatient psychiatric facilities are minimal, especially when it comes to trauma-informed care. Systems for tracking and monitoring critical incidents are disparate and opaque. This graph demonstrates what substantiated and partially substantiated complaints looks like in Massachusetts. And these are complaints that are substantiated by the Department of Mental Health through their mandated reporting system. The top three are treatment issues, physical abuse, and human rights violations. However, data like these are not easy to obtain or work with. A Freedom of Information Act request was necessary to create this graph. And obtaining relevant data to determine something as simple as the number of incidents wrapped up within each complaint could cost tens of thousands of dollars and be delivered in voluminous redacted pages rather than an accessible database. Finally, there is a concerning lack of research infrastructure to systematically investigate basic questions about health and human safety in this setting. This could be due to a lack of interest among health services researchers, lack of priority among funding agencies, or limited data. Data are limited in part because the federal EHR incentive program excluded psychiatric facilities. There is currently no clearinghouse for complaints, safety events. Data are limited in part because inpatient psychiatry is often excluded from national surveys of quality. In addition, the federal EHR incentive program excluded psychiatric facilities. There is currently no clearinghouse for complaints, safety events, and regulatory violations. Therefore, the public cannot easily access information on facility safety, and rigorous systems-level research cannot be conducted. Given these challenges and the vulnerability of patients, we recommend the following. 1, that payers align incentives with patient-centered and trauma-informed care. This could be accomplished through the measurement of patient experience within CMS's reporting program. 2, facilities and regulators must robustly monitor trends and critical incidents. This could include the creation of a clearinghouse with standardized information on safety events, complaints, and facility and patient characteristics. 3, regulators must broaden their standards to include trauma-informed care. 4, data on safety, utilization, and finances must be systematically collected, analyzed, and reported, and funding agencies, such as the National Institutes of Health, should prioritize research on safety within inpatient psychiatric facilities. Inpatient psychiatric care is on the sidelines of efforts to measure and improve patient safety, despite glaring need. In many ways, inpatient psychiatric facilities are a black box system, where patients have little power, their families have little access, and data is either extremely difficult to obtain or simply not collected at all. Patient safety within inpatient psychiatry is in need of considerable attention and should be the next frontier for health policy.
It's not break yet. I'm going to ask some questions. Thank you all. I'm going to throw a few questions out, and then we'll have a few minutes for you all to join in as well. Linda, let me start with you. It doesn't seem, both from your presentation and from the report you cite, that that there's a lot of question about what we need to do. What seems to be is that we're not doing it. And so I guess the question is, given the comments of a few of us at the outset about how much emphasis was placed on safety in the wake of the original Institute of Medicine report, to what do you attribute your findings, which would generally give the sense of inadequate progress?
Thank you, Alan. I think we haven't really identified nurse staffing and the quality of the clinical work environments as safety interventions. I think that's the number one issue, and it's surprising since that was such a major recommendation. There was a whole volume that was called Keeping Patients Safe, Transforming the Nurse Work Environment. It was clearly identified as a major patient safety intervention. Now, it's human nature to look for the magic bullets and the checklists and the bundled care. Interventions were all attractive, and we found out from research that they worked, and maybe we breathed a sigh of relief. But it turns out it's very hard to implement any of those interventions at a 95% reliability level when the work environments, the clinical environments in which care is delivered are so chaotic. And so I think now we have to come to grips with ourselves that we have to change the basic organization and also the safety culture, and these two things are linked together.
Thank you. Traber, I'm interested, following your presentation were a few presentations about communication and resolution. There's a lot of discussion about disclosing errors. My question to you is, where do diagnostic errors fit in the broader theme of disclosing error? How did the people who reported to the data you presented, how did they even know there was an error?
So first, the survey that we collected, that we analyzed, patients could report any type of adverse event. So they talked about multiple errors. And in our sample, the patients, the majority of them experienced multiple types of errors. So they may have had a diagnostic error, also a surgical error, a medication error, hospital infection. So they had a range of them. So they were able to actually, through the survey, select the type of error that they occurred. And for diagnostic error, it included sort of a range. So misdiagnosis was one, but there was also delayed test results, things like that patients could select. But when they talked about the story, they didn't necessarily say, I experienced a diagnostic error. They didn't talk about it in those types of terms. They just sort of talked about their story, what happened in their interaction with the clinician and with staff at the hospital. So they didn't really talk about them in terms of that, but they knew that something went wrong. They knew that something wasn't right, and they wanted to express that. So I think patients maybe think about diagnostic errors a little bit differently than we do, or the terms that we use, although misdiagnosis is common, and we do see people talking about it in those types of terms.
Alan and Tom, I want to ask you the same question, coming at it from slightly different perspectives. Our focus here is on safety. I'm very interested in the question of whether or not different models lead to higher or lower costs. But at the end of the day, as we heard about Betty Moore, what patients are looking for, in addition to whatever compensation may be appropriate, they're looking to make sure that the problem doesn't happen to someone else. They're looking to contribute to a learning health system. That's commonly said by patients. So I'm curious about the environmental implications of this shift. As a lawyer, I can say that in law school you're taught that one of the goals of the tort system is to create incentives to avoid harm. I don't think people who look out on healthcare feel that the malpractice system as a whole does a very good job of converting that broad incentive into actual safety improvement, but at least it's the argument made. Both of you talked about the learning that comes out of the communication and resolution program. So I wonder if either of you or both of you could weigh in on this notion of the degree to which changing the compensation system or the response system improves or does not improve, or strengthens or does not strengthen the commitment of the institution to actually learning what went wrong so that it doesn't happen again.
You want me to start? No, a great question. For me, it's the issue with regard to communication around these events. The liability question has become an important one because people worry about the policy implications. But at the end of the day, for me, from a safety standpoint, what I've found is that our goal is really to get people to talk about and acknowledge that mistakes have happened. That's what patients look for. It turns out from an operational perspective, if everybody in the organization understands that we made mistake A, it actually becomes a lot easier to get everybody to understand that we need to work together to fix it. it helps make it a priority in the organization because, these organizations today, they're so big and there's so much going on. So my personal feeling is that when you tell the patient about it and bring them into it, it also helps keep it higher as a priority because we now have a commitment to the patient to also fix it. And I think that's where these programs, if done properly, can be extremely powerful because they're after you tell the patient about the mistake, it's followed by that commitment to fix it. And I think that's the big piece right there.
I would agree with that, Alan. And, I would add, when I look at the limited progress in patient safety, I think, in my opinion, the number one root cause is challenges that we have with transparency. And it's not just transparency in terms of communicating with the patient. It's transparency in terms of clinicians reporting adverse events to organizations. It's transparency around clinicians' willingness to talk with one another about care problems. And CRPs are such a potent intervention because they tie all of those components of transparency together and provide a structure that goes against sort of our natural impulses as people and as organizations to want to keep uncomfortable information to ourselves. In some respects, the compensation is not the least important thing to the injured patient, but it's in some respects the least important element of a communication and resolution program, but it is an important marker of accountability. So this is really all about culture change and driving a culture where we normalize all different types of transparency.
Thank you. Morgan, I suspect most of the people in the room have not read your paper. It is painful to see the hole the gap that we have in our understanding of safety. I appreciate your focus on data. When I think about what launched the major investments we're seeing in safety, a cornerstone of it was into Err Is Human, the citation to the deaths associated in the plane crashes and the like. But another element of it within systems was moving away from a sense of inevitability, that, central line infections happen, as opposed to we really shouldn't, we have systems to, if we're paying attention, these things shouldn't happen. Can you talk at all about what is and isn't inevitable in the complex setting of a psychiatric institution? I think you could imagine people saying, these are difficult patients, some amount of harm is inevitable. So how do we think about culture change in that setting as we've done in other settings?
Mm-hmm. Is this on? So I mentioned trauma-informed care, and in the paper I don't go into detail about how to implement trauma-informed care. Our paper was not focused at the organizational level, but there is a robust evidence base for supporting showing that trauma-informed care in a culture change that's very similar to a patient-centered culture significantly reduces restraint and seclusion. A lot of papers, they're as high as 99% reduction in restraint and seclusion. There was a recent paper that came out looking at a trauma-informed care intervention in a long-term living facility for people with mental health as well as developmental disabilities and intellectual disabilities, a population that is often characterized as difficult to treat, high risk of self-injury and injury to others, and their rate of restraint went down from almost 7,000 in 1 year to 7,000 incidences to 40-something. So, yes, there is an argument that this is a difficult population, but there are interventions. There is literature out there showing that we can prevent a lot of the harm occurring within these settings.
Great, thank you. We do have a little time for the audience. We have microphones, and ask that you identify yourself as we are videotaping and video casting. We'll start here in the center. We'll go right behind you after. It's coming from the other side.
Oh, sorry. I'm Dr. Caroline Poplin, a primary care physician. I'm also an attorney. I practiced for 12 years before I went to medical school at 40. It sounds like, although there was some discussion at the beginning of ambulatory errors as well as hospital errors, it sounds like you all are talking about the hospital. And in that case, I wonder if you think there's a reason to distinguish between medical patients and surgical patients, because the treatment in the hospital is different. Unless the surgical patient gets into trouble with an infection and then, you're off to the races. So was this all inpatient? And do you distinguish between medicine and surgery? Do you think there's a reason to distinguish between medicine and surgery?
I think that's open to anyone who wants to. Yeah, Linda.
Take a go at that. We didn't have time in this particular paper, but we've looked at the impact of nurse staffing in the work environment, in home care, in nursing homes, to a small extent in psychiatric care. And we find exactly the same things, that when there are not adequate numbers of professional nurses in these environments, it's very hard not only for nurses to be safe, but it's hard for everyone else to be safe, because everyone's building off of that 24-hour surveillance and intervention system that nurses have to mobilize. And so we find the same things, also in ambulatory care as well.
Yeah, Don.
As a fellow primary care physician, I would just say the reason that there was an entire chapter in the IOM report on improving diagnosis in healthcare on communication and resolution programs is that these are applicable across the care settings. Many of them have been developed in the inpatient setting, but diagnostic errors are just as appropriate for communication and resolution programs as wrong site surgeries or other hospitalized type errors. So they're very broadly applicable.
Let's have a few more questions we have right here. Yep. Here it comes, and then we'll go behind.
You can't come from the other side.
That's,
I know. What's up with that?
It's a system problem.
Lynn Quincy, Healthcare Value Hub, thank you very much for this event and this thematic issue on this really important topic. I'm going to fail the quiz on CRP because I have a question and I'm going to commit the sin of a focus group of one. I heard that the model includes apologizing, offering compensation, but what about restoring to health? I mean, what about when you suffer an error and now your health is compromised, and what about doing whatever it takes to restore that person to the best health they can have? Why isn't that part of the model?
It is. I think we just didn't specifically call it out. There's no question that one of the first things that we do in our hospital when somebody's been injured is we make sure that we're trying to get them back to where they were in terms of their health. And when people talk about communication resolution programs making patients whole, one of the key components of being proactive about this is making sure that you're taking care of all their healthcare needs to get them back to where they should have been.
And one of the reasons I stress the importance of developing longitudinal population-based cohorts of patients and families who have gone through CRPs is not only their physical health, but their emotional health can be substantially impacted by these events, and how that evolves over time can change pretty dramatically. So we really need to better understand sort of what's the experience of patients and families who have been harmed by care. How do we support them both in the immediate aftermath, but for the long term? There are some patient and family advocates who feel like the word resolution is not an appropriate choice of words, because if you've been injured by care, even if there's been a financial settlement, the event and its effects goes on for years and years and years, and oftentimes is never resolved. So the field is struggling a little bit with whether that's an appropriate terminology.
Let's go back here.
Hi, Melissa Brown from De Lorenzo Pentagon Clinic. I have a question. So it sounds to me like the CRP initiative aligns with the high reliability initiative, except for the economic portion where you compensate. So I'm wondering, have you looked into how hospitals and ambulatory care clinics who have adopted the high reliability initiative have changed that dynamic, and has it worked by what they utilize?
Want me to take this one? Sure. So CRP work and high reliability work, absolutely, they go together because they involve the cultural piece. They involve identifying what happened and making a commitment to kind of fix every mistake that happens. They go hand in hand. I think just as we've talked about, we're 20 years into talking about patient safety, and I think a lot of us want to see progress move faster. It's just the challenge of moving these systems and changing them that's taking us time, but they absolutely go together.
And this is why I stress the importance of metrics as such a critical next step for the field, because very few organizations have any way of tracking how they're doing with their CRP in a systematic fashion. So to achieve real high reliability in both the prevention and the response to adverse events, those metrics will be key.
Yeah. And I can tell you at our hospital, just to add, anytime we have a major event, our conversation is focused on a high reliability solution.
We'll take one last question here, and right behind you.
This is to Linda Aiken. And today there's an election ballot in Massachusetts about this Proposition 1 about nursing staffing ratios. It's been very controversial, and actually my personal opinion is the nurses have really gotten beat up with a lot of money that the hospitals have invested, saying this is a bad idea, that the regulatory solution is not the answer to better staffing. I wonder if you have an opinion either specifically on that or the sort of the general thrust of what's being debated in my state right now. I'm from Brigham and Women's Hospital and Harvard Center for Primary Care Medical School.
Thank you. Well, we have studied the California ratio legislation that was passed more than 15 years ago. And California still has some of the best nurse staffing in the country and some of the best outcomes. And they also have very good work environments because adequate nurse staffing goes with better work environments. Also, we've published in Health Affairs and other places that safety net hospitals benefited very, very much from the mandated ratios in California. Massachusetts, like California, half the hospitals probably already meet the ratios now. So it's not for the Massachusetts General Hospital that this legislation is being discussed. It's for those hospitals which poor and minority patients tend to go in large numbers. And so a lesson from California is that those patients could benefit from some kind of mandated floor on staffing. I just can add a little note on high reliability care. Nursing wasn't mentioned in that exchange a moment ago, and we use these terms, the high reliability care, program. You cannot ever have high reliability care without good nurse work environments. It's all built, and they're the foundation for high reliability care. And so I think this is one of the issues of your first question to me. Why hasn't anything happened? Because we don't attach nursing every time we say high reliability. And that has to go together as well.
Okay, well, a terrific start to our morning. We're going to take a break, but as we go to break, please join me in thanking our panelists. Our next segment is talking about the role of systems. As I noted at the outset, there's been a tremendous shift in our thinking about safety and particularly about errors, moving from an individual blame and the notion that just people doing a better job could address the problems that we have to examining the role of systems. Of course, there are multiple systems that people interact with, and that's part of the joy of these papers, is that they come at the perspective of not just the healthcare system, but many subsystems within. We'll hear from Pascale Carayon, professor in the Department of Industrial and Systems Engineering at the University of Wisconsin-Madison and the director of the Wisconsin Institute for Healthcare Systems Engineering. Meg Smith, Health Services Research Fellow at the University of Michigan Center for Healthcare Outcomes and Policy and a general surgery resident at the University of Michigan in Ann Arbor. Anjali Joseph, a professor of architecture and Spartanburg Regional Healthcare System Endowed Chair in Architecture and Health Design at Clemson University. Gordon Schiff, practicing general internist and associate director of Brigham and Women's Center for Patient Safety Research and Practice, and the Quality and Safety Director for the Harvard Medical School Center for Primary Care, Associate Professor of Medicine at the Harvard Medical School. Raj Ratwani, Director of the National Center for Human Factors in Healthcare at MedStar Health, an assistant professor of emergency medicine in the Department of Emergency Medicine at Georgetown University School of Medicine. We'll start with Pascale.
Thank you, Alan, and thank you, all of you, for being here, and all of the people who are hearing us through the webcast. It's really an honor to be part of an effort, and a third of it, one of the three panels, is on systems and systems approaches. I would like to recognize the contribution of my co-authors, Abby, Betsy, Megan, and Jim. It was a great team effort to write about human factors and systems engineering and its role in patient safety. When a patient safety event occurs, very often, you may not realize, but very often you call on us and our methods and approaches. There may be many things that are broken or that don't work very well in the systems and processes that led to that safety event. There may have been a problem with the usability or something else that was not adequate with the equipment that people were using, and they were not able to provide and deliver safe care. There may have been distractions in the environment that took the clinician attention away, and therefore a mistake may have occurred. Human factors and systems engineering has therefore contributed quite a lot of methods and approaches for analyzing and assessing patient safety events and near misses. A systematic review published in 2015, and a lot of examples that we describe in our paper show that human factors and systems engineering can make a difference in patient safety. Some of the areas that we've addressed include having an impact on medication safety through better technologies and better systems, better medication management processes, impact on healthcare-associated infections, and also impact on the design of health information technology and medical devices. One of our challenges is sometimes we misunderstood. You might not quite understand who we are and what we do. Human factors and systems engineering is actually a group of different disciplines. Many of us happen to work in departments of industrial engineering, industrial and systems engineering, and then of course we make it a little bit complicated because of our terminology. But what we have at the core of that human factors and systems engineering are what I have on the right side of that slide. First of all is a systems approach. So what does that mean? Well, that means that it's never just one thing. It's never just the technology. It's never just the physical environment. It's never just the tasks and the activities that people do. We look at all of the elements of the system, not only the individual pieces of the system, but more importantly, how they come together. So very often you hear us talk about system integration, workflow integration, process redesign. And so these are methods and approaches that we use to put all of the system pieces together to provide safe care. The other piece of human factors and systems engineering is we actually know a lot about good design principles. Some of my colleagues are going to talk about good design principles, for instance, with health information technology. If you're not doing good usability, you're not going to get good technology. So we have a set of what we call usability heuristics. This is just one example of a set of design principles that we have. We have design principles on how to better manage workload, how to better organize the supply chain so that clinicians have all of the supplies that they need to provide efficient and safe care. And finally, we have a range of methods. And very often that's what happens is you call on us because you need one of our tool, one of our method. And our toolbox is actually pretty big. A lot of it can be organized around what we called human-centered design methodology. And when you think about designing systems and processes, a work environment like what Linda Aiken mentioned earlier on, we need to think about the people in that process, engaging with them, engaging patient clinicians, so that human-centered design approach, a step-by-step approach where we engage the users, the stakeholders, and then use different methods to improve systems and processes is also part of human factors and systems engineering. So besides how we talk, how we write about our methods, there are many other challenges to the spread and adoption of human factors and systems engineering. And many of them are described in our paper and represented on that graph, from not understanding each other, misunderstanding, to things on our side that we could do better in terms of making our methods more adapted to patient safety, but also on the healthcare side, joining us in improving systems and processes. Our recommendations tackle 6 different groups where we feel we need to make substantial improvements so that human factors and systems engineering really becomes embedded in the fabric of care delivery and patient safety improvement. The first target is really us and our students. We feel it's really important that our students get experiential learning. Healthcare is unique, and there are many different aspects of healthcare, whether it's the hospital, the ambulatory care, home health, the home environment. And so we need to help our students through applied projects or internships to really understand what it's like to be human factors professional or systems engineer in such an environment. We also need to help our faculty. There is more and more of our colleagues that are interested in moving in healthcare. So I would challenge all of you to reach out to one of them and help them understand how their expertise can actually contribute to patient safety improvement. Then there are things that need to be done on the side of the healthcare professionals, their initial training, their continuous education. We feel that they need to have, at the minimum, a basic awareness or understanding of human factors engineering and systems engineering. And then there may be some of them that evolve and may become both an engineer and a physician, both an engineer and a nurse, an engineer and a pharmacist. And we're doing some of that work of bringing them up to speed. Almost every other industry has people like us in their organizations. Our paper actually described 2 cases, 2 specific cases, Stanford and then the University of Wisconsin Health System, that have hired human factors and systems engineers, and our paper described different projects that they've worked on where they've demonstrated their value in bringing a different perspective and a different set of methods to improve patient safety. So again, we would challenge all of you here on the webcast or everywhere else to figure out how you can hire people that we train, our students, and not only hire them, but use them and help them be good contributor to patient safety improvement. And that actually includes the organizations that design, sell, and implement technology, in particular health information technology. We think that it's just not acceptable to use good human factors engineering, human-centered design approaches if you're going to put technology in the care environment. And one of the panel members will be talking about that later on. We also think that regulatory and reimbursement agencies have a role to play. We have demonstrated that we can make a difference in patient safety, but we need to figure out how to scale it up, how do we embed human factors and systems engineering across the healthcare delivery continuum, and in particular for healthcare organizations that may not be close to, and then you name it, one of the universities that trains human factors and systems engineers. So how do we create that knowledge and that expertise, and how do we make it accessible to healthcare organizations that may not have all of the resources that others may have? And so we see a role for regulatory and reimbursement organizations in that process. We are actually very encouraged to see a number of federal agencies emphasize and engage with human factors and systems engineering, whether it's the AHRQ Patient Safety Learning Lab, the joint venture between NSF and NIH on smart and connected health. But with all of that happening, we think that it's about time to figure out a bigger national coordinated effort. Linda Aiken earlier on told us about some of the sobering numbers. And so in order to make a difference, I think there are different pieces to the puzzle that need to be added. And we feel that human factors and systems engineering should be a piece of that puzzle. And so we suggest in the paper a national coordinated effort that may bring together different federal agencies, different foundations, large healthcare systems, to really make a difference for patient safety. Thank you very much.
Good morning. Thank you for the invitation here today. I want to take a second and just recognize my senior author, Dr. Amir Ghaffari, in the Department of Surgery at the University of Michigan, where I have the opportunity to not only receive excellent clinical training, but abundant academic opportunities and mentorship. So we're going to talk today about failure to rescue. Failure to rescue is defined as mortality following a major complication. And if we think about kind of the normal course of how this happens in the inpatient postoperative setting, a patient undergoes an operation. At some point during that postoperative course, they develop that first or seminal complication. And if not quickly identified and treated appropriately, they will often go on to develop domino or further complications, ultimately leading to mortality. Now, much of the work that has tried to decrease postoperative mortality had looked very upstream at preventing complications. And while we've made great strides in this area, it's unrealistic to think that any interventions will completely eradicate complications, especially for many of our really highly morbid operations. And so we need to put equal and parallel attention on rescuing those patients who do develop a postoperative complication. And work about 20 years ago actually showed that when we look at hospitals that vary in terms of their postoperative mortality rates, it's how well they rescue patients that's really the driver of that variation. And there was very little difference in the complication rates among those. Now, in the past few years, there's been a lot of work and publications that have come out that have tried to look at targets that we can focus on to improve rescue. And these have been mostly on hospital and macro system factors like ICU staffing and nurse-to-patient ratios. And while undoubtedly important, these only explain a proportion of the variation that we see. And rescuing a patient, for those of us clinically that know, is a very complex, multidisciplinary, and interactive approach. And so we decided to take a slightly different view and look at interpersonal and organizational dynamics and their relationship to rescue. So using the Michigan Surgical Quality Collaborative, which is a statewide collaborative with over 70 hospitals across the state of Michigan and funding from ARC, we went to 5 hospitals across the state of Michigan and interviewed 50 providers. And these providers varied in terms of their specialty and years of experience. So we included attending surgeons, residents, ICU nurses, general care nurses, respiratory therapists, and the list goes on. We asked each of these providers and semi-structured interviewed what they felt were the biggest contributors to effective rescue. And we had near uniform agreement on these 5 factors: psychological safety, or the ability that a provider, no matter where in the clinical hierarchy they are, they can speak up and kind of talk to anybody else in that hierarchy. Teamwork, action taking, early recognition of developing complications before their significant clinical demise, and communication of those early subjective findings that something's just not going right, but I don't have clear, obvious clinical data to support that. Now, outside of these 5 factors, providers uniformly said that psychological safety, teamwork, and action taking were very effective at their hospitals, but they felt they had deficiencies in early recognition and communication. And so we heard over and over quotes, as I put up the examples here, where an attending surgeon said that, "I think identification could be better. I don't think we spot complications early enough." And a senior nurse had said that the more providers we have involved in one patient's care, the more room for errors in some of the information not being passed along, miscommunicated, or misinterpreted. And so when we take a step back and think again to that kind of process or that flow of a patient going from a surgery to postoperative mortality, we think that the efforts need to shift upstream earlier in the process and target early recognition and effective communication of those early subtle changes that start to give us an idea or highlight that a complication is developing. In order to do this and firstly improve recognition, we would argue that hospitals need to provide tools to all providers that help them identify when a patient is just beginning to deviate from that normal course, regardless of their years of experience. And so we have kind of this mantra that competency comes from experience, and while that's definitely true, we also need to provide novice providers with tools that can help them identify when something is going wrong. And so by developing these normal postoperative pathways and improved skills in trend recognition, we hope to be able to help providers be able to identify those early deviations from normal to get the teams rallied together to take a further look at those patients. We would also argue that we need to have better structures in terms of communication from different types of providers, both in terms of the information that they particularly focus on, as well as just how they communicate, the language that they use to communicate those findings, so that providers of all different disciplines can come together and have a shared mental model and not be working in silos next to each other. And finally, if we take a big step back and think of most of our hospitals, the bedside providers, and typically the ones at night when the hospitals are less resourced, tend to be our least experienced. So interns, junior residents, new nurses. And so we need to tool and task these providers with the skill set to work in these multidisciplinary teams, communicate and identify developing complications. And that takes a step back to thinking about workforce development, both in terms of how we staff our units, but also in terms of our education. And so we would argue that given a new focus on multidisciplinary care, that a focus on interdisciplinary and collaborative approaches and professionalism should be integrated into nursing schools and medical schools with collaboration during those. So medical students and nursing students, respiratory therapy students have similar education and are working in parallel during these sessions. Thank you very much.
I'd like to thank Alan Weil, Health Affairs team, as well as the Gordon and Betty Moore Foundation for the special issue as well as for this event. It really is an honor to be here. I'd also like to thank my co-authors, Eileen Malone and Kerm Hendrickson, who are in the room, who share a passion that I have, that the environment that we work in and that we receive care is a very critical part of the system that is necessary for receiving high quality and safe care. One of the main things that the IOM report shone a light on was that bad events or adverse events happen not just because of clinicians or nurses and the care that is provided at the front line, but because of the systems in which we provided care. And I think it's always wonderful to follow Pascale because she provided a great overview of what the system is. Of this, the built environment or the physical environment is one key thing, but often people don't pay enough attention to it because we assume that that's a given. There's nothing that I can do to change my environment. I can train, I can change how people work, but I can't change the built environment. So I think the case I'd like to make here is that the physical environment in which care is provided is a key component, and it should be considered as a part of safety and quality improvement initiative. A little bit about the role of the built environment, talk a little bit about the role of the different stakeholders and the work that they've done in the last 20 years in looking at the role built environment and patient safety, and then some recommendations for moving forward. So within this context, why does environment matter? According to estimates from the Facility Management Institute, about $50 billion will be spent on hospital construction and investments by 2021. And that's a huge amount. And these hospitals, once they're built, will be in place for decades to come. So if you think about a patient room or an exam room and an operating room, these are built multiple times in a hospital. And if they're poorly designed, then as patients, we are the recipients of that poor quality care for years. And the nurses and doctors that work in these spaces will have to suffer the consequences of poor design for every single day for decades to come. So there is an onus on all of us to make sure this is done right. So in our paper, we looked at where patient safety work has been done and where the built environment makes a difference. And there are three key areas where there is research in the area of healthcare-associated infections, in falls, and medication errors. And most of this research has been done in inpatient settings. So what we'd like to contend is that there needs to be more research done in ambulatory care environments, in long-term care settings, and the home environment, because care is provided in all of these settings. In very quick summary, some of the areas where how can design make a difference, you may ask. And that's often a question that I'm asked when I'm talking to clinicians. Why does it matter? The built environment is there. It's an inherent part of the way care is provided. As far as infections are concerned, we know that infections spread through the hands of healthcare workers, through contact transmission with surfaces, through the air and water. If we can design our environments to support hand hygiene practices by placing sinks and hand washing dispensers in easily accessible locations, it can help with hand washing compliance. Think about room occupancy, single patient rooms versus multiple patient rooms, which are easier to clean. Think about rooms that are designed with crevices and corners that are hard to clean, hard to reach, surfaces that are hard to clean. These are the kind of things that the built environment can make a difference. Similarly, with patient falls, again, we know it's a bundle of features that are needed to help improve patient falls, but the built environment is a key factor. Think about the location of the bathroom with respect to the bed, obstructions in the room that prevent people from getting to the bathroom in time, or location of handrails, and other things like that, medication errors. Again, we've talked about interruptions and distractions. How can you make the medication safety zones better designed, with better illumination, well organized, and more ergonomic to prevent errors happening while you're working on medication dispensing? So again, very quickly to summarize, most of the research is inpatient focused. Many of the things that we found through the research is applicable to other settings, but there is a serious gap in terms of what can be applied in these environments. So we do need more research in those areas. Most of the research has been focused on infection. We need to look at other areas such as pressure ulcers and other sort of safety-related issues. Inpatient psychiatric injuries, how can design help with that? There's also very little done on the home environment, so we need more research over here. This table that you cannot read is a summary that you can look at in the paper itself, which will tell you sort of when should you apply these, which of these strategies are applicable in different environments, and when can they be incorporated? Because not all strategies can be implemented in an existing facility, because I know that's a question that's going to come up, that it's a great idea to put in single patient rooms, but my hospital is already in place, I cannot do it. But there are other things that you can do, like increasing the illumination levels or putting the hand washing dispensers at the point of care in an existing facility. So different strategies work for different facilities. So looking really quickly at the role of stakeholders and what has been done so far, the heartening news is that health systems are beginning to recognize the role of the built environment. And usually when they're in the process of building a brand new facility, they will look at evidence-based design and look at what research is saying in terms of implementing features into the new projects. So the VA, the military health system, the Center for Health Design's Pebble projects have implemented evidence-based design. But these projects don't always have a deep focus on patient safety. And also these tend to be one-time investments. Often they're not looking at it on an ongoing basis. When you're building an ongoing work on an everyday basis, the built environment should be considered. So it's not a one-time deal, but it should be a part of ongoing safety and quality improvement initiatives. There have been many programs that have been put in place to improve quality and safety, but the built environment is a missing part of many of these programs. facility standards. The Facility Guidelines Institute publishes a guidelines for design and construction of healthcare facilities, and this is updated every 4 years. This is a very influential document that impacts the design of hospitals around the country. And in 2014, they added a new component about safety risk assessment. So that's pretty powerful, and people are beginning to look at it. There's a new tool that supports it, but there is a disconnect between the facilities folks who implement this and this quality and safety folks. So there needs to be more of an integration of these efforts. Funding in this area is lacking. It's extremely lacking. Maybe HRQ is probably the only funding agency out there that provides some support or some recognition of the built environment. So we need to have more of an effort over there. Also, finally, and I think that leads to my recommendations, is that most educational programs tend to be siloed. There are few architecture programs that provide training in healthcare and healthcare issues, and there are few medical and nursing programs that provide an exposure to design and safety issues, design-related safety issues. So there needs to be more cross-sectional, educational, and research initiatives. My recommendation all stem from these sort of gaps that we've identified, and so there needs to be more of a focus on this, both in terms of funding as well as guideline setting, so that we can move forward in terms of including the built environment as a key part of improving patient safety. Thank you very much.
I'm Gordy Schiff. This is a team I want to thank. Really kind of the diversity of the team, I think, frames what we've done here, where we tried to pharmacists, communication experts, health IT people, to try to think about how we're going to re-engineer electronic prescribing. As people probably know, CPOE, or electronic prescribing, is probably one of the leading advances in terms of creating safety around medication use. And however, as we've heard in a number of presentations, this is a work in progress. And let me just tell you about half a dozen current problems, and then some of the high leverage ideas and proposals that I think are within our grasp that would really impact on every patient and every prescription. So can you imagine, currently, we now prescribe drugs, but we don't provide patients with the information regarding what they're for. So grandma has 20 medicines on her shelf in the medicine cabinet, and she doesn't know what's for what. And even when they bring them in to me as a doctor, I say, what are you taking all these for? I can't tell either often. Number two, the list of medicines a patient is prescribed exists in 10 or even 20 different places. So we've developed this whole field about medication reconciliation to try to reconcile these paper lists, these disparate lists. People are getting medicines ordered in different facilities by different specialists, inpatient, outpatient, and as you'll hear, we say this needs to come together. Again, we spend millions of hours in both inpatient and outpatient settings trying to reconcile these multiple lists that don't talk to each other. After a patient experiences an adverse drug reaction, and I stop the medicine, and I discontinue it in the computer, the patient continues to get this medicine dispensed by the pharmacy, because my order does not flow to the pharmacy to discontinue the medicine. My order to order it in the first place did, but not the discontinuation order. Electronic prescribing transmits the instructions. It's called the SIG, and this is a little bit of a technical one, but it's free text. This is transmitted as free text, and you the pharmacist often has to re-enter it manually. If they send it back to me as a refill, I have to manually re-enter coded information, and there's standards that exist around this, and it's not done. Safety alerts to warn patients about, prescribers about drug interactions and problem drugs, ignored about 90% of the time in many systems. Think about what that means. And computer prescribing software lets you prescribe drugs easily, but not non-drug alternatives. So these non-chemical approaches, which is often safer, it's much harder to prescribe those. So we have 6 prescriptions that we advocate and we spell out in the article to make electronic prescribing safer. Number 1 is to incorporate drug indications into electronic prescribing. The way that this works is by me starting with the indication. So if I start with gout or migraine headache, the computer can actually suggest the best drug of choice. It can compose the regimen without any errors. And this is going to be much more effective. It also will capture the indication to communicate that to the pharmacist, who can consult the patient and put it on the pill bottle. Number 2, a single shared source of truth, medication list online. Now, with Facebook, breaches, etc., Equifax, people sort of saying, oh my God, why are we going to list all of our medicines online? It turns out most of people's med lists are stored in very insecure places anyway, and this would actually create a sort of a standard that would hopefully be quite secure, and we have the ways to do that. And then we wouldn't have to spend all our time reconciling. Beyond an inherently reconciled list, anybody would be able to get their medicines anywhere. If there's a hurricane, people would be able to see what medicine somebody's on. Number 3, this Cancel RX protocol. It turns out there is a way of communicating these cancellations, but it's not being used. And we discussed some of the issues there and what needs to be done to get that up to speed. Number 4, standardized structured SIGs. There's a NCPDP standard for structured SIGs. This has been codified. It's being used in 2% of the prescriptions right now, being written in 2017. Re-engineering electronic clinical support. We make a series of recommendations how to make this much smarter. In essence, one of the key is really moving this upstream. Don't hit the doctor over the head with a bunch of alerts after the fact. Let the computer be smarter in composing the order correctly in the first place. If somebody has renal failure, let the computerized prescription already adjust for that. Several other recommendations. And last thing is we really need to prioritize non-drug solutions. They're often much better in terms of safety for the patient. It should make it much easier for me to prescribe sleep hygiene or other things rather than a sleeping pill for somebody who's having insomnia. So finally, we want to just sort of emphasize that these are all within our reach. These are very concrete, big solutions, but all doable ones that you all should be tracking how we accelerate progress on these. They have enormous safety impacts. They really reside at the intersect of clinical, health IT, and policy. And again, that's exactly what Health Affairs does, and this issue, I think, is about. They would be welcomed by prescribers, patients, and payers. So it's not like one group says yes and the other group says no, making prescribing more efficient, making this better for patients. There's really an alignment there that it achieves both safety and cost improvements. The solutions are at hand, as I mentioned, with agreed upon standards, yet many of them have languished for 10 or 15 years. And what we need is leadership, accountability, investment in these, and again, you all to be saying what's going on in each of these realms. And then finally, these will go a long way to realizing the potential of electronic prescribing, this great hope that we had that this would be a high leverage solution to medication safety. The World Health Organization has set a goal of medication use free of preventable harm. And I think if you go through each of these things, you can see a series of harms that are currently occurring, and this would really take us a long way to radically reducing them. Thank you.
Good morning. My name is Raj Ratwani. I serve as the director for MedStar Health's National Center for Human Factors in Healthcare, part of the MedStar Institute for Innovation, and also in partnership with MedStar Health's Research Institute. And I'm going to spend the next few minutes talking to you about identifying electronic health record usability and safety challenges in pediatric settings. And this work is done in partnership with the Children's Hospital of Philadelphia and the Children's Hospital of Wisconsin, and graciously funded by the Pew Charitable Trust and the Agency for Healthcare Research and Quality. When I was leaving home this morning, my 6-year-old daughter was really quick to point out that orange doesn't work for me, referring to this tie. And of course, my 2-year-old son falls over laughing as part of the peanut gallery. Despite those kinds of comments, we work really hard to protect our children. As a community, we work really hard to protect our children. And in healthcare, and this might sound obvious, we recognize that children are not just tiny adults. They have unique needs. We have unique care processes for them, unique equipment, unique medical devices. And now that we have electronic health records, which are pervasive, used by nearly every single provider in this country, we're running into a little bit of a challenge here, which is that many electronic health records are not recognizing this difference. They're not seeing the difference between adult populations and pediatric populations. And as we look to our clinicians that are treating pediatric populations, this poses some serious challenges. It puts a lot of pressure on our clinicians to interact with these complex systems. Those usability challenges not only lead to clinician frustration and burden, but the really big challenge of patient safety issues. In this study, we focused on looking specifically at EHR usability issues related to the medication process. As many of you are well aware, medication errors can be catastrophic, and they're often the most common. To do this, we started by looking at patient safety event reports from 3 different healthcare systems. If you're not familiar with patient safety event reports, in brief, they're short descriptions, often entered by frontline clinicians, that describe anything from a safety hazard, that is something that could be a risk to a patient but hasn't quite reached them, all the way to a safety event, which is something that reaches the patient, potentially harming them, potentially killing them. Of the 3 healthcare systems we looked at, we took 3,000 patient safety event reports from each system. We did not draw these randomly. We used a natural language processing technique to try and select reports that were specifically related to medication process in the electronic health record. We then manually reviewed all 9,000 of those reports, looking for which reports had an EHR usability issue associated with the medication error. We found that over 1/3 of those reports had an EHR usability challenge associated with the medication error. 3,243 reports, over 1/3. When you look at these reports, it can be difficult to determine which ones actually cause harm. Many times it's inconclusive, oftentimes because that report is entered and then the patient trajectory goes on and not followed up on. From these reports, we were able to determine that 609 of these reports reached the patient. That's 609 children that are directly impacted by the usability of the electronic health record and the medication error that ensued from it. We further defined those particular patient safety event reports by looking at the particular usability issue that was associated with the patient safety event. We broke those down into 4 distinct categories. The first one was system feedback. System feedback is essentially, does the electronic health record software system provide appropriate feedback to our clinicians? Much like if you're placing an order on Amazon and you forget to put in your credit card, you'll get flagged that says, please enter your credit card information. We'd expect something similar from electronic health records with reasonable expectations from our clinicians. The second category was the display of information. Here, we expect that the information presented in the EHR is relevant, uncluttered, and that all irrelevant information is not on the computer screen. The third category is difficult data entry, which is fairly self-explanatory, and the fourth is workflow support. That is, does the interaction with the electronic health record mirror or match the way our clinicians think about doing their work? When we look at the patient safety event report usability issues, we found a very consistent pattern across the 3 sites, which is that the majority of the time, system feedback issues are associated with these usability, with the medication errors. A concrete example of this is a provider enters a medication prescription for a child that's a 5 times overdose, potentially a lethal overdose, and does not receive directed feedback from the EHR despite the fact that that prescription is way out of range. Another example is a child has a documented allergy to penicillin. A physician can't see that for various reasons related to the EHR and prescribes a medication for penicillin with no feedback from the system indicating that there's a documented allergy. If you look at the types of medication errors that follow from these patient safety event reports and the usability issues, over 84% of the time, the medication issue is an improper dose. That is, it's an overdose or underdose that the child would receive. In many instances, it's an overdose, and those overdoses can be lethal. Fortunately, there are several low-hanging fruit policy maneuvers that can be done to improve the usability and safety of pediatric electronic health record systems. The 21st Century Cures Act, passed with bipartisan support, laid the groundwork for many of these. The first one is that the ONC is now mandated to create a pediatric voluntary certification program. They're currently working on that program, and it should be released for public comment. As that program is being developed, it's critical that it prioritizes the safety aspect of electronic health records, not just usability and not other aspects. Safety in addition to those components. The second piece is that the 21st Century Cures Act also mandates that the ONC create an EHR reporting program. This reporting program is intended to bring transparency to electronic health records. One component of that reporting program is usability. We strongly believe that another component should be safety, given the strong tie between usability and safety. They're two sides of the same coin, and many times the very measures that are looked at for usability can also be measures of safety. Third, given that this is a good panel on systems, is we have to recognize that while the two policies I just talked about are focused on the EHR vendor, this is a complex problem with several stakeholders. And we know that during implementation of the electronic health record, there are several customization and configuration choices made by the provider organizations that also impact usability and safety. And just focusing on the vendor design and development process is not going to tackle all of these issues. To address that one, we believe that there's an opportunity for the Joint Commission to look at health IT safety standards as part of their accreditation process. We firmly believe that with these three policy maneuvers, we can hopefully begin to improve electronic health record usability and safety for our pediatric populations. Thank you.
With our presentations running a hair long, I'm going to ask actually only one question. It's a slightly meandering question, but it's really directed to all of you, and maybe we can spend 5 or 7 minutes with you going back and forth. I'm struck as I listen to this collection of presentations, I'm struck around the resource issue of all of these potential improvements that are easier to envision in more resourced institutions that are able to make larger investments and bear and spread the costs of various re-engineering processes across a larger base. I hear the call for regulations that add compliance costs that will be criticized by those who have to bear them, may lead to more consolidation in sectors that has other challenges associated with it. Not to minimize the value of what each of you is describing, I'm trying to figure out the spread strategy so that we don't come back 20 years from now and say we had a session, we identified a bunch of great ideas, and 20% of the fill-in-the-blank institutions have done it and 80% of them have not. The question to me is, to what degree do the various, and I realize there's a broad range that you all talked about, the various interventions that you described, to what degree can we have modular solutions where the more highly resourced institutions can lead the way, as some of you have shown with evidence, and those with fewer resources can adopt at a lower cost so that we can accelerate the spread? To what degree, though, and I'm particularly struck by the failure to rescue paper, are these about responses that have to be tailored to individual circumstances? So there is no modular solution. It requires a site-by-site investment, and there's really no way around it. It's striking that in the last presentation we heard about meaningful use, and of course we as a country did make a financial investment in meaningful use, but it was a complex process that not only included a lot of new resources, but involved a fair amount of criticism about the standards that were set. So that's my wide open question. You've got some great ideas here. What's the diffusion strategy? Meg?
I think from a failure to rescue standpoint, the question of resources and especially financial resources is something that we're particularly aware of and thoughtful about. And that's part of why we first took this different shift to look at interpersonal and organizational dynamics and not things like ICU staffing that are potentially really financially constrained at different institutions. Our hope going forward is that we're piloting some interventions that are really unit and ward based that can be kind of self-regulated and self-initiated, and piloting those at tertiary care centers where there are those additional resources, with the plan to then take those out to our collaborative, which encompasses a wide variety of hospitals and clinical settings, and be able to see how they would adapt them to be efficacious there as well, to then hopefully roll out. But I agree that having the resources, as most of the research is done in these big tertiary centers, is something we have to be really thoughtful about in terms of what interventions we're adapting and creating.
Great. Gordy?
Yeah, I would like to plead not guilty as charged. If we were to ask the doctors, which is what's being currently done, add the indication when you write a prescription, go to another screen and check some boxes, and then we'll monitor that. That is adding work to people. If we were to ask the doctors, which we currently do, if you're worried about a patient when you discontinue medicine, you should call the pharmacy and tell them to stop dispensing this medicine. Okay? These are added steps. The things that we're proposing are actually ways of changing the infrastructure. That's sort of what systems approach is a little bit about, fundamentally, to actually change the whole infrastructure in which people are writing these prescriptions to make less work for everyone. So this isn't a solution that Mass General can do and then we want to spread it to a small community hospital. This is something that if we were able to achieve, implement these standards and things that we've talked about, would basically everybody would benefit from equally, and it would be not work in their part. There would be this economy of scale of doing this in a larger sense. So I think I think this is the key to really making high leverage things. Not adding more steps, not adding more work, thinking bigger, thinking about overcoming silos and leveraging them. So each of these 6 ideas kind of interact with each other. This idea about ordering by indication helps you get for more conservative, options that are not drugs, and decision support. So I think some of this really requires just being smarter, thinking bigger. President Eisenhower, I know we were thinking about elections and Republicans and all this, had a quote, I hope I'll get this right. It says, when I have a problem I'm trying to solve, I can usually only solve it by making the problem bigger and thinking in a bigger way. And I think at least the ones that we're proposing here hopefully can be both conceptualized and implemented in such a way that it doesn't really fall prey to what you're worried about, Ellen.
I like the challenge. Raj, are you?
Sure. So I think my comments would really mirror what Margaret was pointing out. If we look at the health IT space, the health information technology space in particular, for some time there's been discussion around a health IT safety collaborative with the idea of being able to pool resources across institutions and across sectors, by the way, which is critical as we look at the systems approach to try and tackle many of the health IT usability and safety challenges that we're seeing. And I think that would accelerate our ability to develop solutions and would certainly accelerate our ability to disseminate those as well. So I think that's a great model for us to follow.
Pascale?
So actually, I don't think we have a strategy. I mean, I think you're asking us a tough question, and that was part of our final recommendation, that we're still doing piecemeal things. And if we're really serious about breaking down silos and trying to tackle patient safety at the local level, at the organizational level, at the country level, we need to go about it very differently. Because otherwise, I think in 20 years, we come back and we're going to say the exact same thing. So let me just give you a couple of examples. When I hear about interprofessional education, great. And what I hear is physicians and nurses, sometimes pharmacists. What about including other people? What about including human factors professional, architects, communication specialists? What about health IT? I mean, we heard the paper by Raj talking about patient safety problems, and then Raj told us we've been talking about that for quite a long time, and so I don't think we have a strategy, and I think that hopefully the special issue of health affairs will be the trigger to some of us in the room on the webcast to think bigger, and I think that's what Gordy was saying, is to help us think bigger about how do we take some of these ideas and make them more usable and use at the local level, but how do we think bigger, whether it's health IT, medication safety. Otherwise, I think we come back in 20 years, or someone else will come back in 20 years, and we're going to be saying the same thing. So I'd like to challenge all of you to figure out how do we come up with that strategy? How do we get together and break down some of these silos and think bigger, but also think smaller in terms of actual implementation?
Yeah, I think the built environment is one where everyone kind of stops and thinks this is too expensive, we cannot afford it. But the reality is that all hospitals are at some point making small changes to fix things, get things up to code, making small changes. But the folks who are doing that often don't know that there's a bigger patient safety question that needs to be addressed, or this could be a part of something else. So I think linking it with these other initiatives is going to be critical. And the other thing I think is that these learning labs actually are a really great opportunity to start a greater focus on resource-poor settings. Most of these learning labs have been funded by well-resourced universities and health systems, and they tend to do the research in those settings too. But I think it's very important to start focusing more on resource-poor settings, coming up with ideas and prototypes that will actually work in settings that are like in rural South Carolina or wherever where I come from, where they don't have the technology to do X, Y, and Z, or the resources to put into something. But we need to start coming up with prototypes that could be implemented and customized in other settings. So that's my take on that.
We just have a couple of minutes, but let's see if we can get some voices. Someone in the very back there.
Hi, thank you for the great panel. Dr. Joseph, I'm interested if you could explore the question of what patients see in the built environment and the architecture. Often they're looking for really fancy, nice, high-end type finishings and furniture, but that's not necessarily safe, right? So how do we balance those needs?
I mean, I think it can be attractive and safe, but it doesn't have to be high-end and attractive to be safe. So I think, if you're looking for patient experience and sort of their impression about the built environment, sometimes, just having it be clean and safe. And there's also this sort of misapprehension that it has to look beautiful, it has to look like a 5-star hotel for patients to really enjoy the experience. But if you talk to some patients, they want it to look like this is where I'll get good care. So I think a little more exploration of what that means, not that it looks fancy. I mean, I think a stressful environment which is loud and noisy and crowded and unclean or whatever, that's definitely not going to create a better experience or a safer experience. So we have to look at both aspects of it. It doesn't have to be 5-star for it to be safe. And it's, I think, part of the communication too, that we've done all these things, we really care for your safety, and kind of communicating that you don't need to have the most beautiful environment for your safety is the first priority.
I didn't think I had anything to say on this, but how many people staying here last night noticed this is a fancy hotel, right? Bringing their luggage up those steps. Did anybody have a problem with that? Maybe I'm traveling too much. How about getting onto the elevator? Did anyone have a problem when you pushed the 3rd floor, the elevator didn't move? There's no signs about putting in your card there. Anybody else have that problem?
Good design.
Okay, a few. I mean, there are not that many people staying here, but I bet if you did a sort of systematic human factors assessment led by Pascale, you would find I'm not the only stupid person here, or the only one with a bad back. So there's just some basic things that if you listen to the customers, you could say, well, what do they really know about safety? But I think a certain number of these, I think, are congruent with things that are confusing, that are complex. Make it hard for people to interact with built environments that turn out to be safety issues.
Mm-hmm.
Take one last one here in the center. Well, looks like the mic went to someone else. Sorry about that. Here, I realize I have not called on a single person on this side, and I have to remedy that.
I just looking at the overall picture of what a provider has to go through to fulfill safety and all kinds of other requirements, I think there's a tendency for everyone to look at their own silos, think they're thinking big, but not considering what the average day of a physician is. There are webinar requirements of all kinds. There are all kinds of compliance requirements. There's information coming from 100 different places, specialists, nursing homes, hospitals. There are sometimes criminal penalties if they're not done right, all of which everybody admits is leading to burnout, which is going to multiply the amount of errors that are made. So it seems, I'm sure people are doing this, but I think it's really important to coordinate all of this in one place, that just kind of a look at what people have to go through to fulfill this. And I'm not sure this is being done enough. It's being done, But it seems to me these requirements are just multiplying tremendously. And, you know, one more thing.
Actually, let me just let the audience respond to the presenters respond to that. So
Yes.
the notion that human factor involvement does include the energy required to participate in these things.
So actually, I think you're bringing an excellent point, which is what do we know about the walk, the activities that occur at the sharp end? And it could be a physician, it could be a nurse, it could be a patient. God, my God, some of the things we're asking to patients to do, it's a full-time job. And what do we know about what they do? What is the environment like? What is the technology like? And so we make a lot of assumptions, and we think, I know what's good for you. And I think what we're proposing is we need to flip that mental model. We need to think about the need to understand what people do, not what we think they do. You know, in human factors and systems engineering, we talk about walk as done and walk as imagined. I think I know what you're doing. No, I don't until I look at it and walk with you. And so that breaking that assumption and going down to the nitty-gritty of understanding systems and processes is absolutely necessary. And then we need to do the bigger, larger system approach.
Last comment.
I'll just quickly add to that also from the human factors approach. I mean, the goal really is to design out those errors. It's not to take an approach where you're adding on additional burdens to make the system safe. Of course, in complex systems, we need to do that. But from the outset, the goal is to design out errors. And there's some very simple non-healthcare examples I can give you of that. If you look at the error of leaving your ATM card at the machine, it used to happen all the time. You insert your ATM card, you withdraw cash, you walk away with your cash, you forget your card. That error is pretty much reduced to zero now because of being able to swipe. So you swipe your card and that error is eliminated. There are countless examples of that. So if we can bring that kind of mentality in early, you can reduce burden and improve safety.
So maybe you should have swiped your card to get the elevator to go to. But
There's no way to know.
But there's no way to know, and that's the problem.
Dark. I went
Okay.
2 different elevators up and down. Couldn't.
Well, we have one more panel that's going to really focus on what some people are doing out there to address safety, but please join me in thanking our panelists here. We don't have a break and we don't have a lot of excess time, so I'm just going to ask that our folks come up, and as soon as they're seated, I'll begin introductions. As I indicated, this last panel is focused on interventions to improve safety. This is a combination of some policy ideas, some experiments that have been tried, some data from efforts that have been employed.
Hello.
We're going to hear from Bill Berry, Principal Research Scientist in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health and Associate Director of RNA Labs. We'll hear from Jennifer Meddings, Associate Professor of Internal Medicine and Pediatrics at the University of Michigan Medical School. David Classen, Associate Professor of Medicine at the University of Utah. Daniel Brauner. We missing a...
Daniel is not here.
Daniel is not here. Okay. Well, and Bob Berenson, who I do know at the end, is an Institute Fellow at the Urban Institute. So we will begin with Bill.
Thank you so much, and bear with me. I am on the back end of a nasty virus, so hopefully my voice will last for 5 or so minutes while I'm talking to you about South Carolina and scaling safety there in and around the surgical safety checklist. First, let me give you just a little bit of background. It struck me last night when I was sitting in my hotel room that I had been in this neighborhood before. And it took me back 10 years. It turns out that less than a mile from here at the headquarters of the Pan American Health Association was the launch the initial launch of the WHO surgical safety checklist. So life is filled with circles, and for me, this is certainly one of them, returning me almost to the exact same geographic spot. That checklist was, we heard a little bit about checklists before, and maybe we'll touch on it a little bit in discussions later, but that checklist was created not to just improve safety and processes in the operating room, but specifically designed to improve communication and teamwork among the members of the surgical team. A bunch of experts contributed to that, and many of us afterwards spread out around the world with the mission of going out and trying to spread that idea. And we certainly took from Geneva back to the United States this idea that we wanted to spread the use of the surgical safety checklist or versions of it in the hospitals in the United States. It was that kind of thinking that led us to eventually seek a philanthropic grant, which we got in 2010, and create a program that we called Safe Surgery 2015. Now, there's some lessons just in the name, Safe Surgery 2015. It shows how confident we were that we could take this great idea and spread it everywhere. We were going to be done in the United States by 2015. We were going to do multiple states, and South Carolina was our first victim. Now, a lot of people ask, why South Carolina? And it turns out that South Carolina was a very special place for us to work, but it was primarily their own fault that we descended upon them because they asked Atul Gawande to come speak, and he made a trade. I'll come speak if you'll use my checklist. And they agreed, and this project was launched. It was a collaborative effort between the South Carolina Hospital Association. Lori Gibbons is here from the Hospital Association this morning. And we've been working together now since 2010 on this. It's really important to understand that participation in the program was entirely voluntary. There is no mandate to use a tool like that. The Joint Commission mandates certain safety checks in the operating room. It's called Universal Protocol. But the checklist is actually a major extension of that, both carried to the end of the operation when the patient leaves the operating room and also right when the patient comes into the operating room. So it's more than just what people euphemistically call the timeout. That map there shows you the scattering of hospitals across the state. So one of the things I can tell you for sure that we learned in this project is every hospital is not the same. Just the geography in the state of South Carolina surprised me as we traveled around that state interacting with people in operating rooms. The facilities were all different sizes, some big, some little, some obviously quite wealthy, and others serving areas that were quite poor. The program itself, there's some messages. This shows the program timeline, which is actually in the appendix of the article. And I think it's an important thing to look at because it carries some really important messages. When we went down there, just like our naivete around naming it Safe Surgery 2015, we went down there with the idea that it was going to take a couple of maybe in-person meetings in Columbia and maybe giving a series of webinars from Boston, and the hospitals were going to do the work and be done with it. Well, you can see that that's not what it turned out to be. We gave the webinar series 3 times, and we kept adding activities. And there's a message in that. Why did we add activities? Well, it was because we were actually paying attention to when people came and when people didn't come back. And we would try and entice them to come back by adding different aspects to the program. And I think this idea of multiple opportunities, multiple different kinds of things over time so that hospitals can come and go is a really, really important concept to this kind of implementation at scale. So what do I mean by at scale? Well, in 2017, we actually published an article in the Annals of Surgery that showed in a subset of the hospitals, the first 14 hospitals who told us that they had completed their implementation. We separated them into a cohort, used data that South Carolina routinely collects, and showed a relative reduction in mortality following surgery of 22% in the first hospitals to tell us that they had completed implementation. Oops. Right. Now you can see that's not 14, it says 29. Well, since then, we have paired with that a program where hospitals can actually claim, again, that they are checklist hospitals. There's a whole process that the Hospital Association runs that lets them self-certify. So what we did was, over the course of the project, we collected the names, the roles, and whether people showed up to the various events and other activities that we held. And this is an analysis that compares what people from the checklist hospitals, the one who say they use the checklist now, so I make the assumption that they have successfully implemented the checklist, did in comparison to the ones that have not told us yet that they have fully implemented the checklist. And I think one of the things you can see, you don't even have to look at the small print and the details, you can see there's a consistent pattern of more participation that comes from the hospitals that say that they actually use the checklist. But there's some other important messages that are buried in here, and I apologize because it's probably not big enough for you to read from the back. But there is a bar that looks specifically at CEO participation. Now, when this project started, we actually asked the CEOs to publicly commit to their hospital to doing this kind of work. And they demonstrated that commitment by actually signing a poster in the lobby of the South Carolina Hospital Association. Now, it took a little bit to get all the CEOs to commit, but they all did commit. And I can tell you that that commitment does mean something. It meant their signature was on the board, for sure, so it meant that they signed it, but every single hospital in that state participated in this program in multiple activities over time. Every single hospital does not claim that they use the checklist regularly, but they all participated in this program. So the CEOs kept that end of their promise. But what the graph here shows is if your CEO showed up at one of these programmatic activities, the chance that you were in the checklist pile was greatly increased. And the same thing was true if physicians on your staff showed up at those kind of activities. Now, I know there are probably other people in the audience that do a lot of quality improvement with hospitals, and the people oftentimes who attend those kind of meetings are nurses. That was the case here. Of the 1,500 or so interactions, over 1,000 of those interactions were with nurses. Of the 500 people who were touched by this program, about 350 of them were nurses. So this program was crafted for nurses. But what this says is it matters if the physicians show up too. Because if the physician showed, those hospitals also were much more likely to fall in the group of successful implementers. So I have a handful of conclusions that are all in the article, and there's a lot more written there about each one of these, but these are the things that we believe. Successful programs must be designed to engage all stakeholders, CEOs, physicians, nurses, surgical technologists, and others. If your program touches all these people, they ought to be involved somehow in the implementation process. Offering a variety of program activities, both lower touch and higher touch, over the duration of the program allows more hospital and individual participation. There are graphs in the paper that actually demonstrate that. And then finally, this started in 2010. The last hospital self-certified in 2017. Changes take time, and they also take resources. If we expect to change patient safety in our institutions, we need to be patient and persistent. Thank you very much.
Good morning. It's a privilege to present the highlights on our study on behalf of my team at the University of Michigan, thus my color scheme, titled Success in Hospital-Acquired Pressure Ulcer Prevention, A Tale in Two Data Sets, and this was funded by ARC. So our studies focused on hospital-acquired pressure ulcers, abbreviated HAPUs. And a pressure ulcer or injury is a localized damage to skin or underlying tissues, usually over a bony prominence, such as your hip, due to pressure and or shear. They're painful, costly, often preventable, and can be life-threatening, and the severity varies by level or stage of skin and tissue damage, ranging from stage 1, which is simply redness of intact skin that doesn't blanch. Stage 2 is partial thickness skin loss. Stage 3 is full thickness skin loss. And stage 4 is full thickness skin loss and tissue loss, such as muscle, tendon, cartilage, and bone. And thus the cost to heal these varies greatly from stage 1 to stage 2, which cost a few hundred to a few $1,000s, to stage 3 or stage 4, where estimates vary widely, ranging from $10,000 to $50,000 to heal each one, if they ever heal. Now, these are serious complications. So Medicare has several value-based purchasing programs that penalize hospitals with higher rates of the severe ones, stage 3 or stage 4. But it's the rates in claims data since about 2008. Now, as Dr. Brady mentioned, there's also been a very useful national scorecard that also reported a 23% successful reduction, which is great, with a conservative estimate of $1 billion savings, which varies by version of the reports, in HAP use from 2010 to 2014. But this uses chart-based surveillance reviews, and it did not distinguish by HAP use stage. And as many of us who work in wounds realize, chart-based surveillance is likely much more reliable than as it's building claims data. So this inspired our research questions. Did the claims data used for Medicare policy implementations show similar success that we saw in the national scorecard? And how did the success vary by HAP use stage? This slide shows our main results to quickly orient you that y-axis is the incidence or number of HAP use per 100 discharges, ranging from 0 to 4.5. That x-axis is the year of data that was looked at, ranged from 2009 to 2014. I'll first draw your attention to the red line. The red line is that HAP use incidence that included all stages from that chart-based surveillance by the Medicare Patient Safety Monitoring System, or MPSMS. And that improved from 4.02 in 2010 to a 3.09 with a relative decline of 23%. Now, they have recently changed the methods, so there'll be a slightly different baseline moving forward. But I'll next draw your attention to those much lower rates, that dark blue line and that orange line below. That comes from the claims data that is used in all of our value-based purchasing programs to score and penalize the hospitals. The dark blue line is the rate of HAP use all stages, ranging from 0.27 to 0.16, which thankfully at least is a reduction. It was statistically significant, but you're starting at such a lower incidence in the claims data. That orange line is the actual metric that is stage 3 or stage 4 by the formal metric that is used for comparing hospitals, and that applies a few exclusions. So overall, HAP use incidence did decline in claims data, but has a much lower incidence overall from that of chart-based surveillance. Our next question is how the declines we saw in the claims data declined by stage. Now, quickly, I just talked about those low rates at that bottom, that blue and orange. Focus on that. I'm going to blow it up. So on this slide, you'll see that incidence y-axis now only goes from 0 to 0.25 so that you can actually see what's going on in the claims data. We divided that dark blue line into those early stage 1, stage 2, which is that light blue line, and the later stage, which is the dark blue line. And you can see that there was a significant decline in the early stages from 0.24 to 0.13, and that was statistically significant. But when you looked at those later stage ulcers, which are the ones that are more severe, more costly, and more morbid, there was technically a statistical significant decline, but it's really going from just tiny numbers that they're almost 0, and how it is recorded in this claims data that is used for all of our value-based purchasing policies. So overall, there was a 96% decline in the HAP use incidence in the claims data used for our value-based purchasing. But it was due to a decline in the less severe stage 1 and stage 2 ulcers, which simply by definition and literature is a much less expensive HAP use. And so just a few quick policy implications of our findings. We believe that Medicare should consider using a chart-based surveillance system that mirrors the current data collection that's actually used for hospital-acquired infections. Instead of claims data alone, to compare and penalize hospitals for HAPUs, given these very large differences in HAPU incidence by data collection strategy. And these differences have not just been found in our study, they've been found in multiple studies. We also believe that HAPU surveillance in the future, and I say this because I understand the MPSMS system is being considered for revision to a new system, should account for a HAPU stage. Because we believe as clinicians it's better to understand the impact of the actual changes or not that you're making in HAPU incidence on patient morbidity and cost savings, because it makes a big difference if you have reduced your HAPUs by 23% in mostly that intact reddened skin, stage 1, compared to a 23% increase, ideally in the future, in those hopefully rare but severely morbid stage 4, which go down to the bone and sometimes never heal. Thank you very much.
Thanks very much. I'm David Classen from the University of Utah, and I also work for Patient Safety Organization. We have 2 members of our team. You might raise your hands who are in the audience, Drew Ladner and Michael Lee. Thank you all for being here. And today I just wanted to briefly talk about a look forward in safety. Much of what we do in safety is retrospective, related really to voluntary reporting of incidents and everything else. What if we could build a system of the future that actually used automated information to surface safety problems as they occurred in a time frame when we could validate them and measure them more accurately, in a time frame when we could help the patient? So you're having a complication, let's help you, and perhaps in a time frame where we could predict it before it occurs. So this is a real transformation in how we view safety, a real-time safety surveillance system using current EHR technology. And so that's essentially what we did. We built using current EHR technology such a system and implemented it and piloted it at 2 hospitals. So a look forward really here. And the reason we could do it is because of all these opportunities. Meaningful use, broad adoption of electronic health records, and this approach, because we are better in interoperability than we might think, worked with the 4 leading EHR vendors. So we've gotten to a point where interoperability, you can make this kind of system work with today's technology, no further. In addition, almost every article in this series has said, although we've made improvements in harm, there's a whole lot of harm we can still reduce. So these systems might be very, very valuable. But there are a number of challenges, and we spend a lot of time in the paper talking about them. You know, very few of adverse events based on chart review ever get reported. Most of safety measurement right now in the United States is based on voluntary incident reports or based on claims data, administrative data. And as you can see here, they miss most of the boat. So we're measuring safety based on a very small number of reports. We're probably measuring based on less than 10% of what's there. So a modern surveillance system that could pick up all-cause harm would be a real advantage to what we're doing. And so we've created a highly illustrated example of this. I don't really expect you to see any of the fine print, but basically what we are able to do with this system is surface safety issues that may or may not represent harm to the patient. What's an example? You're on Coumadin and your INR gets really elevated. That would be an example of a safety indicator. Now you may not have a problem with that, or you might. And so what we did in this system was surface that, allow a clinical reviewer to look at that elevated INR, go see if the patient had any bleeding, and if they did, document it, and if they found that, intervene to help the patient. So we call that sort of the real-time safety, patient safety active management system. Then we went a little further because we did all this within a patient safety organization. All the hospitals correlated all their data, and after they ran the PSAM for a while, created a huge data set that allowed us to go to the next step, which says, can we use all this information to predict safety problems before they occur? And that's the pane down on the right-hand side. And that's an actual real-world example, and we could actually calculate a score every hour if we wanted to on patients in the hospital to show their risk of having a complication while they're in the hospital. And as you can see in this patient, that patient came in with a slightly elevated score right here. It went down a little bit, and then it started up. And on about day 4, it started to rise, and by day 6, they had their first adverse event. And then they had their next adverse event. So what we showed in the study is you can actually track this over time and predict it before it occurs. And here are the things we call patient safety indicators. Some people call them triggers. They're things in your chart that go awry, that show that care is not working just as you might want it to. For instance, your glucose is out of control. For instance, your kidney function gets worse while you're in the hospital. Or somebody gives you an antidote like vitamin K. These things don't necessarily represent harm, but they do represent a deviation from care. And out of the 147,000 admissions in this study, we found 775,000 of these deviations from care. So care is not nearly as reliable or standardized as we might think. And so when you show these deviations in care to clinical reviewers, they can then go find absolute harm associated with them. And this is the harm we found in this study. And in the old days, we really mainly cared about these things because they could be used to find these things. Now we know, interestingly enough, these things on their own may be a predictor of bad outcomes in terms of mortality, length of stay, and readmission. So we're really, I think, learning a lot about how an active safety monitoring system might not just be based on harm, it might be based on precursors of harm, what you might call a near miss. So let me just give a couple examples of that. In this study, if somebody had an adverse event, they clearly had a higher mortality, but look at the rate of readmission. That's the highest rate of readmission I've ever seen. So people who had complications in the hospital had a 30-day readmission rate of 22%. Really dramatic. So these are really significant problems, and they have downstream impact. We have another study coming that looked at a year of data after hospitalization and found that these patients had risk of readmission and mortality increases and increased ambulatory resource use for a full year after they left the hospital. So the complication didn't stop at the hospital door. We tend to think of these things as temporary. But look what happens to these safety indicators we call triggers. Look at the difference between people who had them versus people who didn't. Clearly an elevated mortality risk. Look at the readmission risk. It's really dramatic. So this may change how we view what we thought were just minor deviations in care. They may actually have a long-term impact. It may pay to follow these things closely. In addition, I won't go into this. We looked at the ability of that safety predictive score to predict adverse events. Worked out quite well. 30-day readmission and mortality. So it does seem to have an impact and it can predict. But many asked us, why are you just showing this to healthcare workers, including the Robert Wood Johnson Foundation? And they said, if you have this real-time safety information, why don't you show it to patients and their families? So we mentioned this in the article, and it gets called out in the article. So we actually did a trial of reconfiguring all this information that made sense to patients and families and showing it to them. And the first thing patients and families went after was the safety predictive score. They wanted to see that, and they wanted it to work across the continuum of care. We built that using data from EHRs would automatically calculate what's my risk of developing a safety problem. The other thing patients were very interested in were what we refer to as triggers or the safety indicators. And patients wanted them turned into a real-time checklist for them. So your trigger or your indicator said, I have a positive urine culture, that might be a safety problem for me. Why don't you convert that into a language I understand? Why don't you then tell me what questions I can ask about that to my healthcare team? And why don't you give me more information on things I can do to mitigate that risk? And then finally, give me information that I can get more for my family. In addition, the patient said, we want this to work on every platform. Laptop, we want it to work on our iPad, and then we got to the iPhone. And this was the real game changer. When we put this on the iPhone, people started using it like crazy. And I think the bottom line in all of this is, let's look forward in safety and think not only how we can surface this information to healthcare workers, how we could surface this information for patients and their families. I can tell you based on this trial, patients felt safety was their responsibility because they always mentioned in our design groups as we redesigned all this that when they left the hospital, safety was up to them. They had a complication. So they felt very empowered by this information. So I will stop there with my conclusions. I think the only other thing we talk about in the article that's probably worth emphasizing is clearly we can do this. It's not a barrier technologically, but it's probably going to be a barrier for many other reasons for this to be adopted. And we can talk about that in the questions and answers. Thank you.
Hi, I'm a geriatrician and an ethicist at the University of Chicago who's had the good fortune to work with a team of very talented economists, health economists, statisticians, and physicians on several projects studying and analyzing long-term care. I began caring for patients in nursing homes back in 1985 in an early wave of the recently created specialty of geriatrics, foray into what we called teaching nursing homes at the time, pre-Ober, when nursing homes were very different places, essentially warehousing and sedating older patients. The shocking deficient quality of care in nursing homes prompted an early Institute of Medicine report back in 1986, a less well-known report titled Improving the Quality of Care in Nursing Homes. And this really led to the Ober legislation and the Nursing Home Reform Act of 1987, which informs a lot of the quality initiatives in nursing homes today. 13 years later, the 1999 Institute of Medicine report to Err Is Human ignited the patient safety movement, but its focus was safety in the acute care setting, and this focus appears to have bypassed the quality focus in nursing homes. Safety in the IOM sense of preventing harm to patients from medical errors can be seen as a separate domain of quality. Quality measures not considered to be safety by us, safety motivated, including that are important in nursing home care, are listed here. Improving or maintaining functional status, treating pain, maintaining weight, avoiding physical and chemical restraints. To show how this history played out today, we picked several safety measures that are important aspects of quality in nursing homes, which is just a small segment of the larger quality issue, to see how they influence nursing home Compare, a national program intended to rate the quality of care in U.S. nursing homes. Towards this end, we analyzed merged data from the first quarter of 2017 from the Nursing Home Compare archives with the data from the certification and survey provider Enhanced Reporting, or CASPR, to create a nursing home level data set. CASPR is a compilation of data collected by surveyors during regular inspections of nursing home facilities for Medicare and Medicaid certification. We examined 6 key measures of safety in nursing homes, and these are listed here. Pressure sores in long and short stay residents, urinary tract infections, injurious falls, and 2 measures of medication errors. Here we see the Pearson correlations, 1 being perfect and 0 being none. And actually, they are negative correlations as expected, since these events should negatively correlate with the star ratings, 1 to 5. Here we see the very low correlations between these measures, both with Nursing Home Compare overall and when compared with just the health inspection data. This data is graphically presented here. The average percentages are calculated as the unweighted average across facilities in each star category of the reported percentage of residents who trigger each measure. That is the average of facility triggered percentages. With the exception of medication errors, we see a fairly flat response between the star ratings and the occurrence of these measures. except in the medication errors. This is to be expected since Nursing Home Compare is heavily weighted by health inspections ratings, which are strongly affected by deficiencies such as medication errors. Otherwise, we see little difference between the star ratings and the occurrence of the negative safety outcomes. So we concluded from this, when we consider safety in nursing homes, we need to also think about quality of life, because once we start considering safety, this can have a negative sort of association, a negative correlation with factors that really impact on quality of life, such as autonomy and self-determination. Be that as it may, Nursing Home Compare does not provide consumers with much information on which to judge patient safety. And patient safety measures have not been well integrated into the nursing home setting. And as a policy implication, we suggest that Nursing Home Compare should strive to achieve a more comprehensive picture that reflects all domains of quality, including patient safety, which necessarily implies looking at more at quality of life in nursing homes, both of which are currently vastly underrepresented. Thank you.
Good morning, or it might be afternoon by now, something. So I co-authored a paper with Hardeep Singh, who's a professor of medicine at Baylor and the head of the Diagnosis Improvement Safety Center at the Houston VA. He is one of the country's experts in identifying and documenting and researching diagnosis errors, and I'm a payment person. I worked at CMS, and so this was an interesting collaboration. And we have a paper called Payment Innovations to Improve Diagnostic Accuracy and Reduce Diagnostic Error. So, as you've heard, and Jeff Brady did a great job, so I don't have to do it, earlier talking about the problem of diagnosis errors. The IOM report was called Improving Diagnosis in Healthcare. It's both a quality problem and a cost problem. It gets largely ignored in the policy arena. I work a lot in the policy arena. Happily, months ago in September, a group of over 40 organizations actually finally got together 3 years after the publication of the IOM report to start a collaborative or a coalition with each organization taking on a certain aspect of trying to improve performance for diagnosis. But interestingly, there was no representative of any payers on that 40-plus organization coalition, or anybody who knew anything about payment, who had payment expertise as their special niche. And so basically we have this sort of initiative, broad initiative, starting pretty much with the Affordable Care Act, that we're going to move from volume-based payment to value-based payment. But so far, the issue of accuracy of diagnosis shows up nowhere in the agenda for improving value through payment. So our paper is designed to start the trek to improve payment, to at least recognize the problem of diagnostic error and maybe even improve performance in diagnosis. One of our reviewers commented to us that we should have had a roadmap with specific stops along the way to get to what we would envision as how to pay to reduce diagnosis errors. I would use the metaphor, we just want to put this issue on the radar screen. So we have provided a number of suggestions in our paper without, to get the discussion going, because it doesn't exist right now. Now, as we would expect, and I agree with this, fee-for-service, as represented by the Medicare physician fee schedule, which is a class fee-for-service, or in, say, DRGs for hospitals, which is a volume payment model, is agnostic best about diagnosis accuracy, and at worst actually promotes it. I mean, you can be working up a patient incorrectly for months and get paid adequately for it. There's really no relationship between the accuracy of the diagnosis and the activity that generates payment. But I would argue, we would argue in our paper, even worse is the lack of attention to diagnosis accuracy and alternative payment models. Some APMs, or in fact most APMs, require the accuracy of diagnosis, yet the payment designs incorrectly assume accuracy as presented in ICD-9 coding on claims forms. So basically, many of the payment models just accept the diagnosis that shows up and submit it, in the case of Medicare, to Medicare. They're often wrong. There is, as we cite in our paper, there's significant evidence of misdiagnosis of even the most common conditions, cancers of various kinds, congestive heart failure, COPD. And we're not talking about 3 or 4% misdiagnosis. We're talking about double digit in the 20s, 20, 25% misdiagnosis for even those very common conditions. And yet all you have to do in some of the alternative payment models is have a diagnosis on the claim form, and you get a whole stream of payment for 6 months or 12 months or whatever the circumstance might be. We don't have performance measures related to diagnosis accuracy. Admittedly, measuring diagnosis is very difficult. Sometimes people die without the correct diagnosis. But what we have are payment models that just assume the condition, and if many conditions have low severity, and simply designating the patient with that condition, if that generates a large payment stream, we're actually not improving value, we're actually decreasing value by the significant excess spending that's going on. Population-based payments, for example, to ACOs for care for a population, requires accurate diagnosis-based risk adjustment, again, accepting reported diagnoses. Yet this is somewhat old data, but I'm pretty sure it hasn't changed significantly. A diagnosis of congestive heart failure on a claim form in year 1 is only, the term is persistent, it only persists 50% of the time in year 2. Was the congestive heart failure cured? Did the patient actually have congestive heart failure? Those are the questions that are just sort of accepted in risk adjustment. So we propose 3 areas for improvement. In fee schedules, create collaborative care codes. CMS is actually has been very active recently in coding for services, activities that don't involve the patient sitting in front of the clinician. We suggest that is a precedent for actually working on collaborative discussions amongst various clinicians, diagnosticians, to get a diagnosis correct. There's been a lot of attention in the NPRM and now the final rule that just came out last week on eliminating the documentation guidelines that often create inaccurate medical records. Information that's just cut and pasted and moved forward. Ideally, we would get rid of those. And above all, we need to correct fee distortions to allow more time for clinician-patient visits and associated workup. Right now, a primary care physician would get paid more for interpreting an EKG, something that takes about 15 seconds, given that it's already been interpreted by the machine, rather than spending another 5 minutes taking an adequate history with a patient. We have real distortions in what we're paying for. Our second area of improvement would be to create APMs that have as a major objective improvement in frequently misdiagnosed clinical presentation, including support for centers of diagnostic expertise and other approaches to get expertise for challenging diagnoses. In Q's and A's, I can elaborate a little more on that. But ultimately, this is what I think needs to happen right away. Confirm that the diagnoses that generate long-term APM payments have evidence that the patient actually has the diagnosis. That might include second and third opinions, more oversight and perhaps penalties for incorrect diagnosis. Perhaps most importantly of all, encouraging quality improvement activities focused on assuring accuracy of diagnosis. For example, having ACOs all have to commit to quality improvement activities. Through that process, we might actually get some measures that we could be using more generally to improve the situation. Thank you very much.
Okay, I'm going to run through a couple of quick questions, and we'll just have a few minutes for the audience before we run out of time. But let me just run down the row here. Bill, you highlighted the finding with respect to CEO and physician involvement, even though nurses were the primary touch points. Based on the multiple interactions, can you expand, can you at least posit a hypothesis? Is this about creating the time and space for the entire organization to participate? Is it about a culture shift and moving away from blame, although this was about checklists, so maybe it's a little different? What's the mechanism that you would hypothesize that relates CEO physician involvement to being in that?
My extensive anecdotal experience,
I love it,
across the state of South Carolina, the culture of an institution I found emanated a lot of times from the C-suite. And I observed that pattern over and over again. And they were the same ones who showed up. They were the same ones who visited their ORs. They were the same ones who would go to a team meeting and watch a team use a checklist. So I think that's part of it when we talk about culture. Culture has to start, I think, a lot of times at the top of the institution. As far as the physicians are concerned, and we talk about this in the paper, they're very torn creatures. Because they have a lot of responsibilities, and unlike the nurses, a lot of them when they show up to these meetings are not on the clock. Now, the ones who did come to the activities, a fair number of those physicians were on the clock. And so maybe that speaks to differences in the way that physicians in particular are paid. But, like I said, it was absolutely associated with success. If the chief of surgery showed up at a meeting with his team, it made all the difference in the world. And, that could just be who they are too, and they take that back home to their own institutions and they end up being local champions, which I think is really important.
Thanks. Jennifer, I want to move a little bit away from the technical differences between claims data and chart-based. I was thinking if we had done this issue 5 or 8 years after Err Is Human, we would have had lots of papers on voluntary and mandatory safety error reporting systems, and somehow we don't even have a single one. So I wonder if you can help us think about, obviously, chart-based. The reason we use claims data in a lot of places is because it's cheaper. And chart-based surveillance or specialized reporting systems have other costs associated with them. So I just wonder if you can, again, the findings are striking, but can you pull us back to thinking about, given what we're trying to accomplish here, how much can we rely on administrative data at all?
Sure. So the policies that involve removal of payment for hospital-acquired pressure ulcers, those occurred 10 years ago in 2008. And that initial policy was very well based upon why would you link it to claims data. That policy simply said we will no longer pay hospitals extra when that patient gets a hospital-acquired pressure ulcer while they're admitted, so it had a clear link to claims data. And so it wasn't so much the purpose, its initial link was for rating or penalizing for overall rates. They were publicly reported from claims data for a few years. But so with that policy in 2008, it had a very direct, logical link to claims data. But then, unfortunately, as the focus for trying to get more skin in the game, more penalties for these different complications, there was the advancement to the hospital-acquired reductions policy, which is also very well intended. It actually used a composite measure that only has a small piece of pressure ulcers as part of it, but it also relies on claims data because that is the data that was available. But unfortunately, the piece that was missing was before we actually compare hospitals by their rate, that's incredibly rare in this claims data, and then actually enact financial penalties, do the validation of that within the claims data, and that's what was missing. Now, it is encouraging to know that there actually are hospitals that actually use something besides claims data to look at their own pressure ulcer rates. This was actually done routinely in California. It was actually mandated in the earlier years. We actually published a paper, I'm happy to share about that, where they actually did quarterly mandatory surveillance by a trained team in that hospital that actually knew how to correctly apply stages, and they examined every patient in the hospital. And these were prevalence rates, and these were publicly reported. The paper that we had done actually showed that unfortunately these much higher rates in that type of surveillance also had very little correlation. So we clearly could see that even the claims data scores aren't even a signal for who's a good performer. And so fortunately, I think for the future, there actually are some important new opportunities. I know that there's looking into sort of changing or advancing the MPSMS system to a newer system that I forgot the name, but it's more complicated, that actually has the potential to link to actually electronic medical record data that actually could link to nursing data within it, as opposed to just the claims data, which is unfortunately linked to how often physicians bill it. The other thing is there actually are also some nursing-led research projects where there are hospital collaboratives that actually already voluntarily report these prevalence rates using chart-based surveillance, using standardized criteria, and they figured out how to do it within the resources of the hospital. But unfortunately, it hasn't been nationalized yet. So there's a lot of great opportunities I'm looking forward to seeing, but I think it's really time to just move away from claims data for this.
Thank you. David, it's hard to read the paper, which I've done, or listen to it without going, wow, this is like the next frontier. And it's quite striking. I have this, I listen though, even before you get to the engaging the patients, which I think is wonderful to get there. We've heard so much about alert fatigue. So how do we not let risk of a safety error become just another alert that becomes just another bit of noise that folks tune out?
My nephew's a Delta pilot. He landed his MD-90 at Atlanta Hartsfield Airport, and they took all the passengers got off, and then maintenance came on and said, you know, your pilot, while you were landing, the brakes started to heat up. It didn't get hot enough for us to tell you about it, but we are monitoring the situation constantly, and we're going to take the plane out of service. The reason I say that is the first place we did this automated safety alerting, we sent the information to frontline nurses and doctors who promptly told us, don't bother us, we're very busy. Create another way to do it. So what many of the hospitals involved in this initiative doing are creating alternative methods of creating a real-time safety measurement system that somebody else is doing as a service to the frontline clinicians, and only get the frontline clinicians involved if it exceeds a threshold or requires intervention. And I do think that's going to be the model. And aviation's been doing that for years. They don't talk much about it, but they've been doing that for years. And I think that's where we'll go too. And the question is whether the patient should be part of that or their family. So in the trial I told you about, patients love the fact their family could access this as well. And if they were in their hospital bedroom sick, their family member could be watching. So think of these alternate surveillance models that I think are probably going to be a big part of the future. You know, when you go and put your ATM card in a bank and in an ATM machine and something screws up, somebody's watching that. Not people in the bank, someone somewhere else, right? So I think that may be the model.
Very interesting. Interesting. Thank you. Daniel, you at the outset noted that quality, thinking of safety as a subset of quality. Now I'm thinking of the patient or the resident or the family making a decision about a nursing home. What do we know about people's assumptions about safety in that setting? Is it sort of I think they're all safe, so I don't know what to do with this information? Is there a sense of an understanding of a spectrum and that maybe I should pick somewhere? I mean, the whole premise here, or part of the premise here, is better information for making choices. That requires a model of how people map information against choices. What do we know about that model?
I'm afraid, we don't know that much. I mean, we really have not talked to consumers about this a lot, and I think that's an important area that needs to be elaborated on, obviously. I think at this point, I would assume that consumers are very concerned about the safety of their loved one in a nursing home, and I think that's a basic need that people feel for their loved ones. They want them to be safe. In addition, they would love it to be a nice place where the people are happy and they have a good quality of life. But I think at its very basic, the very basic thing is that they want them to be safe in that place. And so I think there needs to be a lot more attention paid to safety issues which are not being paid to in things like nursing home care.
And Bob, you at the outset talked about the conversations that didn't include payment. Now I want to sort of take your three areas and look at the role of patients, which has come up throughout the course of the morning into the afternoon. How do you see patients fitting in to these areas, potential areas of improvement around, for example, you mentioned confirming diagnoses with additional opinions, but how do we get some of the frontier of patient involvement into your work?
It's a very important question, and clearly a simple answer would be that patients want to spend more time with their clinicians if you ask them. I'm assuming that if we actually paid more adequately so that patients wouldn't be cut off after 23 seconds or whatever that study showed, that would be useful. There's a technique, I'm actually blanking on the word, that Dr. Del Banco at Harvard promoted for giving patients access directly to their electronic health record and permits them to actually correct and introduce additional information. Does anybody remember Open Notes? Yes, Open Notes is something that the IOM committee thought might have some real potential. Some organizations like Geisinger and others have adopted Open Notes as a way of allowing patients to correct what's often misinformation in the medical record. So there are probably for every one of these things, there are ways in which patient involvement can be increased. I don't have sort of a global answer. I tend to be a splitter rather than a lumper.
Well, I didn't intentionally run out the clock, but we do promise people that we will start on time and end on time, and we've had a really full day. So at this point, what I'd really like to do is thank the Gordon and Betty Moore Foundation for making the issue possible. Thank you all for attending and participating, and please join me in thanking our final panel for the day.